testing dekat sini. Dia letak. Dia saya dah kepada komputer punya mikrofon.
Dia keluar.
Yelah, tapi dia tak ada testing
Testing. tu. Boleh tangkap kan?
in. Ada kan? Ada.
Okay, Assalamualaikum and a very good morning. Thank you all for finding time to join today's webinar on strengthening prevention of mother-to-child transmission, PMTCT, of HIV and syphilis program in Malaysia. Updates on PMTCT guidelines, which is organized by the HIV, STI and Hepatitis C sector of the Disease Control Division, MOH, Ministry of Health. My name is Dr. Muhammad Izzat Anwari, and I'm the Principal Assistant Director at the Disease Control Division, Ministry of Health. I will be the moderator of this two-day webinar. First and foremost, we would like to thank the National Institute of Health, NIH, for co-organizing today's webinar with us. Just a little housekeeping before we get started. Please register your attendance at the link at the WebEx chat box. We understand there's an issue regarding the YouTube that we cannot connect at the moment, but our IT team is currently rectifying the issue. Just click for the ones that can able to go through WebEx chat box. Just click at the relevant link if you want to ask any questions or you want to register your attendance today. If time doesn't permit, we will try to answer through your email if we aren't able to answer all the questions at the Q&A session after the speaker speaks. Okay? Now I will talk briefly on the objective of our webinar today and the agenda as well. I hope everyone can listen to me at the moment. Okay. A little bit of background of the current guideline. The Director General of Health has recently endorsed the second edition of the Strengthening Prevention of Mother-to-Child Transmission, PMTCT, of HIV and Syphilis Program in Malaysia guideline on the 28th of June 2021, just recently, about 3 months ago. This is to ensure that Malaysia still retains its achievement of the first country in the World Health Organization, WHO, Western Pacific region to be certified as having eliminated mother-to-child transmission of HIV and syphilis. Congratulations to us. So for our webinar, for our two-day webinar, our objective is the first one to update and enhance all health practitioners on the current knowledge and management from the new guideline. And the second one is to highlight issues or shortfalls of current management of PMTCT program in the Malaysia setting. So just as a recap, for our agenda today on the 27th of September, we will have a keynote speech by our very own Dr. Anita, which I will give more explanation later. The first topic will be given by Dr. Nurul Aida. The second topic will be given by Dr. Nick Mazlina, and topic 3 will be given by Dr. Karit Erwan. For further information regarding the presentation, I will brief later. So, as a reminder, please register your attendance at the attendance link at the YouTube description or the WebEx chat box. We understand YouTube is we're still rectifying the issue with YouTube. For the ones who can access WebEx, please register or ask any questions using the link provided. Questions to speakers can be submitted using the question link, as I mentioned before, at the YouTube description or WebEx chat box. We will try to answer questions during the Q&A session. If time doesn't permit, we will try to answer through your email. Don't worry, your questions are all registered. We have the information, and don't worry about being left out. We will try to answer all questions. If not, during the Q&A session, we will try to answer using your email, through your email. So the last reminder is to make sure your internet connectivity is good. We all know that internet connection is essential during our current era with all the online lectures or classes or webinars. So make sure it's good. All right. Now, without further ado, we'll turn over to the first speaker who will deliver the keynote speech, Dr. Anita Sulaiman. Dr. Anita is a consultant public health specialist and epidemiologist at the Ministry of Health Malaysia. She has more than 20 years of experience in HIV works, ranging from providing primary care services at implementation level to crafting innovative strategic plans, guidelines, policy, and national investment case for HIV in the country. Currently leading the National HIV STI Hepatitis C program at the Ministry of Health Malaysia, her involvement in getting the country validated for elimination of mother-to-child transmission, PMTCT, of HIV and syphilis is instrumental. She also has vast experience leading the country's HIV estimations and projections, conducting integrated biobehavioral surveillance, IBBS, survey and population size estimations for key populations in the country. The latest edition of HIV work is combating stigma and discrimination against PL-HIV at the government healthcare settings. Dr. Anita will give a keynote speech entitled Strengthening of PMTCT of HIV and Syphilis Program in Malaysia, What's New in the PMTCT Guidelines. Dr. Anita, the stage is yours.
Thank you very much, Mr. Moderator, Dr. Iza. So for a kind introduction, today I'll be talking the summary of what we have done, where a little bit on the epidemiology of HIV and syphilis, and I will try to highlight the difference or what's new in the new guideline. Okay, please bear with me. I think I will share the slides with you. Okay, take some time. Can you see this? Okay, all right. Okay, now. Please bear with us. I think we are still, I'm still trying to shift or change the page. It's not able to. Okay, all right. Now, ladies and gentlemen, I think if for the first timer who have never heard about PMTCT before, PMTCT stands for Prevention of Mother to Child Transmission program that currently entails covering for HIV and syphilis in the country. Now, for MTCT, MTCT means mother to child transmission. So when we said MTCT, it is also similar to, or in other words, also same as vertical transmission. Now, MTCT for HIV accounts majority of HIV infections in children aged 0 to 14 years. And what is important here is that MTCT for HIV and syphilis both are preventable. Now, based on this principle, Ministry of Health has initiated prevention of mother-to-child transmission of HIV and syphilis more than 20 years ago for HIV and more than 30 years ago for syphilis. I think if most of you, could still remember during med school, syphilis has already been part of the antenatal care alongside the HB, VDRL, blood grouping and so on and so forth. So much so that we all thought that syphilis is part of, it is a routine program, and we tend to forget to stress on the importance of coming early to ensure that each and every mother who come for antenatal care in our clinic or in-house hospital get syphilis test. So I think this strengthening of PMTCT is timely. We did not have any specific document on syphilis screening or syphilis program in our guideline, but we do have for HIV because HIV is rather new. So HIV started in 1997. So while I was there, you know, when it was started, so the document is there. You can find a document in year 2000 and that's been amended a few times. But syphilis, we don't have any specific document documenting the process, the workflow and things like that because it has been part of the antenatal care. But you do find syphilis screening mentioning in the perinatal manual under the MCH department. Okay, now talking about PMTCT, Prevention Mother-to-Child Transmission Program for both HIV and syphilis, the implementations are based on four-pronged approach. The first one is prevention of HIV and syphilis in women of reproductive age, which is 15 to 49 years old. And this is, of course, the best approach we could implement it wholly or countrywide. The second prong is in prevention of unintended pregnancy in women living with HIV. But this is important when you talk about unintended pregnancy, especially among serodiscordant couple. We need to educate them to make them understand and make informed choices. So this is where the health education to serodiscordant couple would focusing on ensuring safe sex or safe pregnancy. Okay, so talking about the prong one just now, the prevention, it is more on the awareness program that is currently ongoing at schools, premarital screening. So all are actually towards preventing infections among women of reproductive age. The third prong is PMTCT, HIV syphilis that we are going to talk about today and tomorrow. And this prevention of mother-to-child transmission of HIV and syphilis can be achieved through screening, early detection and prompt treatment. And for HIV, it is about giving antiretroviral therapy, adhere to the treatment, achieve undetectable viral load. And for syphilis, it's about giving penicillin-based regimen during pregnancy is not other than penicillin, but penicillin, because penicillin is the only regimen for syphilis that could prevent congenital syphilis. Right, so our speakers will dwell more about the treatment for HIV and syphilis during pregnancy, and it also achieved through ensuring safer delivery practices, whether it is cesarean sections or whether it is spontaneous vaginal delivery, and it will also be touched by our panel speakers. And the third one is through continuous counseling and education regarding adherence to treatment, infant feeding methods, and also family planning, and so on and so forth. So all this topic regarding PMTCT will be touched by our panel speakers. And the fourth prong is continuum of care for not only the mothers who are infected with HIV or syphilis, but also covering the partner or spouse, and of course the exposed babies. So it's a life stage education, I would say, right from premarital, and then during antepartum and intrapartum, postpartum, the partner and spouse, as well as the baby. This is a life stage education. Okay, now if you can still remember the transmission or vertical transmission, mother-to-child transmission of HIV, if there is no intervention, about 25 to 40% of infant exposed to HIV infected mother would be born with infections either during pregnancy, during labor and delivery, and also during breastfeeding. So this is when we don't have any intervention. But the important thing is that with intervention, when those mothers, when they come for antenatal care and we screen them for HIV and they are found to be positive HIV, and we give them treatment as soon as possible during antepartum and continue through life, right, forever and ever. And for mother who breastfeed for the first month of 6 months of life, we are talking about mother on ART, and she breastfeed the baby for the first 6 months of life, but 5% of infant may be infected. So we can see the drastic reduction of MTCT HIV if intervention is implemented with regard to initiation of antiretroviral therapy and also feeding practices. Now you can see that about 3% of infants do get chance for HIV transmission during breastfeeding. It's a small or slim chance, but it can be overcome if we ensure that HIV infected mother who wish to breastfeed the babies to ensure that they adhere to the treatment and viral load is suppressed. Okay, now let's look at the achievement for Malaysia 20 years back for HIV and syphilis. So we can see that from 2010 till now, at any point in time, Malaysia has achieved more than 95% of antenatal mothers, whether they come to the government facility or whether they go to the private facility, 95% of them, at least 95% were given HIV testing and treatment for those who are positive. And the treatment for those who are positive achieved almost 100% in Malaysia. But if you look at the seroconversion for HIV and syphilis range from 0.04% to 0.07%. So we can see that the seroconversion is rather stable among antenatal mothers in Malaysia. So the services have been there, okay, so people don't never, so far it is an opt-out approach. So far we have not received any disagreement to undergo HIV test or syphilis yet. But well, I would say that Malaysian antenatal mothers are obedient and they trust the government, they trust the healthcare providers who do the best for them and for the baby. So hence, we have not received a single case who rejected HIV tests and syphilis tests during antepartum. Now, having screening done and treatment given, appropriate treatment or adequate treatment for syphilis, we can the right graph is showing the trend of HIV vertical transmission or mother-to-child transmission of HIV and syphilis. Okay, now the yellow line graph is showing a decline pattern of congenital syphilis, and for Malaysia we have been constantly keeping this congenital syphilis rate below 50 per 100,000 live birth. Now our last 2020 is, I think there is a sudden increase from 2018 and onwards. Although we have seen a remarkable decline of congenital syphilis from previous year to 2017, we're seeing an increasing trend from 2018, and this is mind-boggling. Although it is still below 50 per 100,000 live birth, this is something that we need to address. Hence, the strengthening of PMTCT is timely. As for HIV, MTCT, or vertical transmission for HIV, for the first time in 2016, Malaysia has achieved below 2% of vertical transmission rate among babies exposed to HIV infected mother. So if you can see that it has constantly maintaining below 2%. And with this achievement, Malaysia, Malaysia has fulfilled the criteria for elimination. Now, these are the indicators for elimination that has been set by the global community, global strategy for elimination of MTCT, HIV and syphilis. So it is divided into two main indicators, the impact indicators and process indicators. As shown in the graph before, we can see that the antenatal coverage for HIV as well as syphilis testing has achieved above 95%, and so did the ART treatment for HIV positive mother, and penicillin treatment for syphilis infected mother has achieved above 95%. But what is important here is the impact indicator for HIV, that we have maintaining less than 50 cases per 100,000 live birth for HIV, and the MTCT rate has achieved below 2% since 2017. And for syphilis, we have been maintaining MTCT for congenital syphilis to less than 50 cases per 100,000 live birth. However, from 2018 onwards, we can see that there is a sudden increase, right? And because of this achievement, Malaysia for the first time have been validated for being eliminated mother-to-child transmission of syphilis and HIV in 2018 based on the data of 2016. All right, so in 2018, we became the first country in Western Pacific region, and in fact, the first Muslim country globally that has achieved this elimination. Okay, now let's look at a little bit on the landscape of HIV in our country. Now, for HIV in Malaysia, this infection is still predominantly among male population. However, we can see over 10 years, 20 years, from 1990 to 2020, 30 years, right? Okay, within 30 years period, you can see a sudden increase or slow or gradual increase of female infected with HIV. Now, we can see the specific rate of male and female. We can see a rather stable infection rate of HIV among female as compared to male, but there was a sudden decrease in 2020. But as we all know, because of this COVID-19, most diseases or most people stay at home, so they don't come forward for testing, though that could be a reason why we are not testing enough. Okay, now this is also very important to show because if you recall back the previous slide that I showed you here, all right, the sudden increase of congenital syphilis from 2018 to 2019. This is among infant, yeah. Now look at this syphilis incidence rate among adults, all right, or in total population. So there is the blue lines is showing a total of syphilis incidents as reported by the surveillance system, national surveillance system in Malaysia. So we can see a worrying increasing trend of syphilis infection among Malaysian population. Now, if you look at clearly which actually category that contribute to the increase of syphilis, it is obviously the increase of syphilis infection in Malaysia is contributed by the male population, while the female are rather stable. Now, this is very worrying though, because of we anticipate increasing syphilis infection among antenatal mothers in the future if we don't emphasize or focus on screening and testing and treating those mothers early enough to prevent congenital syphilis. So we anticipate there will be an increase of syphilis infection among antenatal mothers looking at this trend, because I think most of cases syphilis among antenatal mothers, they are not aware that they are infected with syphilis, because majority are still getting the infection from their spouse, right? Okay, now there are issues and concerns that the reason why we need to strengthen our PMTCT. Number one is we see an increasing trend in congenital syphilis, and this is also in line with increasing syphilis incidence general population. The reason because of increasing congenital syphilis, from the analysis of our previous congenital syphilis cases, we found out that the reasons, among reasons, are inadequate treatment. Mothers are not given proper treatment, adequate treatment. I mean, in this case, for syphilis, to prevent congenital syphilis, we need penicillin B. But of course, there are mothers who are allergic to penicillin. So our speakers will touch on those allergic on penicillin, so what should be done. But if there is no clear indication, penicillin is the treatment to prevent congenital syphilis. So we found out that some hospitals, especially in private sectors, are still treating pregnant mother with non-penicillin based regimen. So this should not be the way in the future. The next one is opportunity for adequate treatment missed, especially when the mother comes in for the first booking a bit later, maybe during the second trimester. So we did find some antenatal mothers who actually came quite early during first trimester, but somehow the system has missed because of the turnaround time of RPR in the health clinics, for example, because in some clinics they don't perform the RPR during the same day, so mother will be called later. So this is where the system, is giving, there is a gap in the system that allow mother to go back, and for those who are high risk group, they may default treatment or they may default antenatal care, so we're going to miss them. So this is opportunity missed that we should address if we want to sustain elimination of MTCT for HIV and syphilis. And most importantly is that for syphilis, we have never stressed before or emphasized before that it is very crucial that the mother must be adequately treated with penicillin-based regimen. Adequately treated means at least one dose 30 days prior to delivery. So this is where the catch is, because for HIV, the interventions is rather straightforward. Even though the mother is unbooked, even though we can test them during intrapartum, even though we still can give them a bolus dose of antiretroviral during intrapartum, and that is considered intervention, and it still has a good impact to the baby. Unlike HIV, the syphilis counterpart is a bit different. Infected mother with syphilis need to be treated with penicillin-based, at least one dose, 30 days prior to delivery. So this is where prompt treatment is crucial. So this is where in this PMTCT guideline, we strengthen on the to ensure adequate treatment. How best can we deal with mothers who come late, late bookers, those may not have the potency to default, for example. So how best can we tackle this category of mothers so that they come in the first day itself, they get tested, and if they are positive, they get treated the same day. All right, so this will help sustaining elimination MTCT of syphilis in the future for Malaysia. Now, the second issue, which is also very important that has never been addressed before, is the human rights issue, especially among antenatal mothers, postpartum women living with HIV. The sexual reproductive health rights has often been forgotten or just being neglected, I would say. So I would not deny that stigma is still prevalent among healthcare providers, whether it is in private sectors or also whether it is in government sectors. This has led to late booking or mother goes unbooked or default treatment, especially among marginalized population, right? So this is where stigma, all right, prohibit those who are especially the marginalized group from coming for booking, early booking, antenatal and follow-up and so on. Okay, the next issue which I would want to highlight here is that has been brought up by women living with HIV. This is not what we postulate, but that's what has happened before. And this is complaint that we receive from women living with HIV that our healthcare provider forced them to go for sterilization. So this is against human rights. Hak asasi manusia, you know, they have the right to continue getting pregnant. They have the right to whether to feed the baby with formula feedings or their own breast milk. They have the right, but as healthcare provider, this is where the weakness is. We found out that healthcare providers are lacking in terms of communication skill. So often the advice being mistook as forcing or coercing those mothers to go into tubal ligation and to take or to shift from giving breast milk to formula feeding, you know. So often when we speak to the doctors and the healthcare providers, they are advising those mothers, but the way they speak to the mothers, you know, they often mistook for being, you know, for forcing them. But the third one, which is still prevalent, and it has happened, about discrimination in the ward. So recently, we conducted a survey among women living with HIV, those who have delivered in the past 3 years. It's quite recent. There are a case who complained that they were placed in at the end of the session, at the end of the ward, and worse still, they were given disposable plates. So it looked that they are so infectious, so they are given you know, disposable plates, whereas the other postpartum mothers who are in the same ward are using the normal utensils, usual plate. So I think this is something very shameful if this happened in our own hospital. I mean, in this our country, very own country. So this should go. Setting condition for ART is very important because ART, they have women living with HIV, antenatal mother who are positive have the right to start treatment anytime. And it is, you know, there are cases where our healthcare providers set a condition that if you don't take ART, or if you don't breastfeed, if you continue breastfeeding your baby, if you don't want to give your baby infant formula feeding, we do not want to give you ART. So this is something very, very wrong, and I would say it is crime because you deny the rights of health to these mothers. And lastly, family planning option. There are a lot of, there are multiple methods, family planning, you know, where barrier methods, you know, IUD and things like that. It is sterilization is not the only method, right? Okay, now I would like to share with you, this is our survey that we conducted 2020 and 2021 among healthcare workers. We look at the attitudes of our own people and government health facilities towards women living with HIV, and we conduct interventions and we re-evaluate them. Now, these are the three indicators. Number one, healthcare workers neglected women living with HIV during labor. This is very true. I mean, this is relevant to hospital labor room. So I hope our friends, our staffs, especially from the hospital sides, please focus on this. Although it is small percentage and it is showing a declining trend from 6% to 2%. We do, if possible, we do not want this to happen, if not even to one case, right? All right, the second indicator is healthcare workers imposed compulsory contraceptive as requirement for ART. Not only contraceptive, compulsory contraceptive, also compulsory infant formula feeding. Okay, I'm not going to show the infant formula feeding here, but this is quite worrying. You know, I think more than half earlier, last year, more than half of healthcare providers imposed compulsory contraceptive to our women living with HIV as a requirement for antiretroviral. And for 8 months, there was an intervention that we implement for hospital, selected hospital and selected health facility tackling these issues. So Alhamdulillah, we can see declining from 60%, almost half, the attitude has changed. So what possible, we want this to go even further down. And the third indicator is that our healthcare workers, I think about 1/5 of our healthcare workers agree that it is appropriate to sterilize women living with HIV. Although there is a declining pattern in terms of the attitude, there's still a lot more to do, right? Okay, now we also conducted a survey among women living with HIV, looking at their experience when they seek healthcare, whether antepartum, intrapartum, as well as postpartum. Now, there are 5 indicators here. We can see also pre and post. The pre was 2020, before intervention. So, and then the blue graph is pre-intervention, and the red bar is post-intervention, right? Now, unfortunately, we don't see much changes in terms of the experience by the women living with HIV. It is indirectly showing that our services, antepartum, intrapartum, postpartum, there are a lot more to do with regard to stigma and discrimination. Now, the indicator 1, ART given if taking contraceptive, this is still, I think they still face, women living with HIV still face this issue, okay, with regard to stigma within the healthcare provider. Indicator 2 is advised not to have sex. How can we advise people or human being not to have sex? I think this is against human rights. So this is in fact increasing, not decreasing. For this indicator, lower is better. So we want to see the rate bar lower, right? But it is not happening. So obviously something is not right with our system. We need to erase or eliminate stigma and discrimination among healthcare providers if we want to make sure this antenatal mother, especially among high-risk population, keep on coming back for follow-up and so on and so forth. Okay, indicator 3, advice not to get pregnant. All right, it's not good still. Indicator 4, ART, if baby on formula feeding, if the mother choose to breastfeed, they will be denied ART. So this is against, to me, this is a crime that we have, which is not supposed to happen in our healthcare facility. And last indicator, it's advised to terminate pregnancy because of the HIV status. So, ladies and gentlemen, this guideline strengthening PMTCT is timely because in this guideline, I will share with you what's new in this guideline, what we need to strengthen in our guideline. Obviously, stigma, discrimination, human rights issues is something that need to be strengthened every now and then during our continuous capacity building. All right, now, okay, my few slides after this is just highlighting what's new in our guideline. I hope we have your previous or old versions of PMTCT, and this new guideline is available for downloading from our MOH website. So if you can see that we focus on improve and comprehensive service delivery. Now that encompass antepartum and intrapartum and postpartum. This new guideline emphasizes on screening the importance of ensuring that each and every mother are given opportunity to get tested for syphilis and HIV. Now, in this guideline, we also introduce the use of rapid diagnostic tests for syphilis, especially in selected areas, interior, because there are healthcare facilities that do not have on-site RPR. So therefore, mother has to come back again. And you know that those who stays or reside in interior areas, it's difficult for them to come back a week later just to view the result. If they're positive, you have to come back for treatment. So it would be much better for certain cases like those potential to default mothers, those who come late booker, and those who stays interior, like for example, orang asli, or even in Sarawak deep interior where some of our healthcare facilities do not have on-site RPR. So there is a place for rapid diagnostic tests. So our specialist will speak to you about introduction of syphilis rapid diagnostic test. I think if not today, maybe tomorrow. So please focus on that, right? I'm not going to dwell much what is it all about. So I'm just telling you the highlights, introduction on syphilis rapid diagnostic test. So wait for that. Okay. Now the second one is importance of adequate treatment. So I think there wasn't any guideline for syphilis treatment for antenatal mother. Therefore, in this PMTCT, HIV and syphilis, we include the importance of treatment for antenatal mother who are infected with syphilis. So it is important to adequately treat it with penicillin regimen for syphilis positive mother. Please focus on syphilis because syphilis is on the rise, right? And the third is continuous education mothers. Samples of health education materials we include in our new guidelines. So healthcare providers, please, you are free to use the samples, health education materials when you educate our antenatal mothers. And the education must be continuous. It's not one-off kind of things. You know, during antepartum, every follow-up mother should be reminded over and over again the importance of adherence to treatment, the importance of coming back for early infant diagnostic, the importance of taking prophylaxis for the infant exposed to HIV, the importance of coming back complete treatment 30 days prior to delivery. This is very important to ensure baby free of congenital syphilis or HIV. So this new guideline also stress on the delivery options, which previously I think we did not stress on options for delivery, so much so that I think previous guideline we enforced on cesarean sections for all HIV positive mothers. So with advance in treatment, we have a better outcome now. Mother with very low load, they can go for spontaneous vaginal delivery and even breastfeeding. Okay, so we're going to emphasize that in our new guideline or strengthening guideline on infant feeding. And lastly, the family planning methods. These are all actually talking about the service, improving on our service delivery. So start talking about family planning methods to antenatal mothers or women living with HIV. There are several options of family planning methods, not only sterilization. Okay, we also talk about in this new guideline about data quality. Now, for syphilis, it is very important that all stillbirth mother must be tested with syphilis, and if it is positive with VDRL and TPHA, notification must be made for stillbirth, and the diagnosis is made as syphilitic stillbirth, and this is following WHO surveillance definition. And if you see in our e-notice now, syphilitic stillbirth is already notifiable, is already being included in the e-notice for syphilis. It is a requirement, mandatory to notify syphilis or level syphilis, whether it is probable, whether it's syphilis or syphilitic stillbirth. So please make sure that all antenatal mothers who give birth to stillbirth, VDRL and TPHA being done immediately. If they are positive for VDRL and TPHA, please notify the nearest district health office, or you can use the e-notice platform, notify as syphilitic stillbirth, and that is counted towards elimination of congenital syphilis. All right, and also I would like to take this opportunity that which is very important to start reporting, documenting all HIV, syphilis, both government and private and universities providing antenatal care. So our district health office will, and also maybe state state health department may come to you, the private sectors, whether the GPs or the hospital, private hospital, they will start collecting data. This is important because when we talk about elimination of MTCT, HIV and syphilis, we are not talking about service provided within government context, but it is throughout the country that also include the private sectors. And this new guideline, we also include the importance of like a quality assurance that include both health clinics, hospital. So we encourage health clinics and hospital, private and government, to participate in external quality assurance to ensure that if you say if the result is positive, it is positive. If it is negative, mean it is negative. So the quality part has always been neglected. So in this new guideline, we emphasize on the importance to participate in EQA or external quality assurance, and for government health clinics, interlab comparison has been initiated, I think since last year. However, it has been put on hold because of COVID-19 burden. Okay, human rights is also being strengthened or focused in our new guideline. So my advice on healthcare providers, whether in private sectors as well as in government, please take stigma and discrimination seriously. It is a real issue. It is still prevalent among healthcare providers. Our healthcare providers still stigmatizing and discriminating our women living with HIV. And please bear in mind that women living with HIV or women infected with syphilis, not all of them are key populations. Even they are key populations, they still have the rights to health. They have rights to get treatment. They have rights to get confidential privacy and confidentiality maintained for their case notes and their records and things like that. And it is their rights to get to be informed about the best way to deliver or to give birth or feed the babies, right? So do talk to your patients, to your clients, continuously talking every opportunity, whenever the mother comes for antenatal care, postnatal care, please talk to them again, over and over again. You know, it is not one kind of, if you talk to them one day and you think that's enough. No, it's not enough. You know, people tend to forget. We need to talk to them every opportunity. Okay, so again, please stress the communication skill. If I mentioned earlier, our advice often been mistaken as forcing them, okay, or enforcing them, right? Okay, so forcing or enforce pregnant women to follow medical advice in order to benefit her fetus will only cause harm than good. So because at the end of the day, these mothers will avoid healthcare totally, and the baby or the infant are not benefiting anything from this, from our own behavior and attitude, right? Every woman living with HIV has a fundamental right to freedom of choice. I know that some doctors feel that, you know, that they say that women living with HIV, you know, there are cases that keep on getting pregnant every year, especially those who are coming from low economic population or quarters, and also a key population. Yes, we do have this case, but they are isolated cases. The majority of cases, you know, they accept advice. This is our responsibility to keep on educating them until they understand and they make informed decisions. It's them that make decisions upon or based on our good advice. And it is rare for a woman to refuse medical advice that promises benefit for their own infants or their own babies, and poses little risk to her. It is troubling when it happens, because the thing is that in most cases, when we talk to those mothers who are positive, the reason why they are not coming back is because of the stigmatizing behavior and attitude by healthcare providers. So you see, ladies and gentlemen, why I want to stress so much about stigma discrimination, because it is still very prevalent in our healthcare settings. So please, from now onwards, be more compassionate, because God is not only testing them, God is also testing us. Well, you know, how we behave towards them, right? Because if you want them, you know, what goes around comes around. If you want people to treat you or your beloved ones right, so we have to treat other people also, you know, as how we want others to treat us and our loved one. Okay, now I'm not going to dwell much about this, but what I want to show you here is that throughout the continuum of care from antepartum, intrapartum to postpartum, at every level, there are critical points where stigma and discrimination can happen, can occur, right? So this is where that every healthcare provider should look into why it happened, right from here. When patient datang or when the mother comes in, they are unmarried, and they are coming and they keep on coming back every year. They come back for dental care, so you can see how we behave towards them, right? So this is where the stigma, discrimination, and the rest, right? So at every process of service delivery that we provide at our healthcare facilities, there are critical points for stigma to happen, right? And on the leftmost column here, okay, I listed here the human rights to remind us the rights to information, right? So continuous education to antenatal mothers and continuous capacity building to on our own healthcare providers is very crucial if we want to eliminate stigma and discrimination. All right. So please be reminded that again, right to information for about option for delivery, about benefit of completing treatment to baby, about option for family planning, and option for breast for infant feeding. It is them, the women living with HIV, who make the decision, informed choice, and it is our duty to give rightful or accurate health education to them. All right. Okay, and this is for the critical point during delivery. Okay, in hospital especially, I put that 3 star there because it is still prevalent, especially during intrapartum. We have received very sad remark from one of our women living with HIV who said that during intrapartum, no one is coming and check on them frequently. They were just left in the labor room because they are positive. So I hope that in the future we don't hear these sad stories anymore. And we have to change our attitude through continuous capacity building. Right? Okay. And I'm not going to. What I'm showing you here is that the stigma and discrimination happening at every process of care that we are providing. So we are proud that Malaysia is among the top, among the country globally that provide the best service, the best healthcare services. Are we really providing the best healthcare services? So if you look at these instances, well, I didn't know. You think about it, right? Okay, so I want ladies and gentlemen, especially healthcare providers, talk to your mothers about appropriate family planning, right? Preferred dual contraception. Talk to them to space out the pregnancy. They can go on, they can get pregnant again and again, but space out the pregnancy and guide them so that they have a safe pregnancy, which is when the viral load has become very low or undetectable. Okay, there are still hope for them. Women living with HIV, there are still hope that they can get pregnant without transmitting the virus to the baby. Okay, all right. Okay, finally, take home message. Thank you for listening. Right, so I hope in these 2 days you will listen to each and every speakers because they're going to talk to you about the services and the process of PMTCT, HIV and syphilis, right from antepartum, intrapartum, and postpartum. And lastly, during delivery of services, do communicate, learn how to communicate, facilitate, practice what we said all this while, patient-centered. So it is not health-centered, it's patient-centered. So if the mother is potential mother and you think that the mother may have syphilis, you know, when they come already so late, please facilitate to get early results and early treatment. Strategy information is very important. Documentation, and consistency at all levels. So please, I know we do not want to burden our healthcare providers with written, but written data, strategic information is the only way telling us whether we are on the right track or not. and lab quality improvement, please focus and participate in quality assurance to ensure positive means positive, negative means negative, right? We are talking about other people's life, so the quality of results is very crucial. Now, capacity building, especially focusing on communication skill among healthcare providers and awareness on stigma and discrimination. Understanding the root cause of stigma at healthcare setting is very important because that is the only way to eliminate stigma and discrimination among healthcare providers towards women living with HIV and syphilis. And last, I would encourage health facility to do regular checking or auditing, review all each and every vertical transmission or NTCT cases, do an auditing on each and every cases, HIV or congenital syphilis, and see and understand which critical process that is preventable, and we have to do strengthen the system and the process. And lastly, ask about our service. Are we doing right? Okay, with that, thank you very much. I pass over to the moderator.
Okay, thank you, Dr. Anita, for the brief and concise keynote speech. We hope that now that all of us would have a better understanding on the background of PMTCT for HIV and syphilis in Malaysia, especially on the issues such as mismanagement or stigma that will lead to inadequate treatment on the patients. And hopefully with the new revised guideline, it addresses those issues. As what Dr. Anita said in her presentation, God is testing us all. So please show compassion to everyone, especially our patients. So another update, we would like to apologize for the initial hiccup on the YouTube. However, YouTube is now up and running. For a better view of quality while viewing your YouTube, please go to setting and change quality to 720p. Okay, so I got info that our viewers are close to 1,000. That's very good news, and thank you all for your commitment. And another issue we got that on the WebEx platform, there's some people are saying there's audio problem. We would like to advise that you should off your camera by stopping the video for a better audio. However, I would like to advise just go to the YouTube link that we provided in the WebEx and stream from YouTube. It will be much easier. Okay. So, all right, since all of us are already warmed up, let us go to the first topic of the day, which is management of HIV in pregnancy at primary care level. This will be an interesting topic, especially to those ones working at the KK or GP. The presentation will be delivered by Dr. Narul Aida. A brief introduction of Dr. Narul Aida. Dr. Narul Aida Saleh is a family medicine specialist at KK Kuala Lumpur, Klinik Kesihatan Kuala Lumpur. She obtained her medical degree from University of Malaya in 1992, followed by Masters in Medicine, Family Medicine, also from UM in 2002. She has special interest in HIV management at the primary care level and has successfully set up the HIV STI clinic in KKKL, better known as Dr. Nurul among her staff and patients. She is heavily involved with HIV outreach work with a few NGOs around KL. She is often invited by Malaysian AIDS Council, JAKIM, HIV NGOs, and JKN to give public talks on HIV, STI, and hepatitis C to those infected and affected by HIV. And she was chosen by the HIV community to win the Community Choice Award for Healthcare Providers 2020. She is also involved with the write-up of a few HIV guidelines at the national level. Welcome to Dr. Nurul. You may proceed.
Thank you, Dr. Iza. Can you hear me? Can you hear me, Dr. Iza?
Yes, Doctor. Yes, Dr. Nurul.
Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. First of all, thank you very much for the organizing committee for inviting me to share this session. So, jadi saya akan guna bilingual, because I understand half of the audience paramedics, healthcare providers, either from hospital or primary care setting. So, so I will be talking about management of HIV in pregnancy at the KK level. Okay, right. Okay. Slide. Okay. So these are my references. Jadi most of my slides will be from our latest garis panduan and also from BIVA guidelines 2018. Jadi bila kita bercakap mengenai management of HIV in pregnancy, jadi at KK level, jadi basically we have 4 strategies ya. Jadi when we manage all these ladies, number 1, it starts with early detection of HIV and syphilis in pregnant women, and we are also targeting at early infant diagnosis. Secondly, jadi we want to provide complete and adequate treatment for mother and her partner or spouse, and prophylaxis for HIV exposed baby. Thirdly, so kita nak bagi continuous health education related to HIV and syphilis to mother and healthcare providers. Dan fourthly, we must make sure that so there is enough capacity building on HIV and syphilis for our healthcare providers. Okay. Jadi, so bila kita ada jadi pregnant woman attending antenatal care, jadi so what is important is to provide them with health education, and so generally kita bagi general information jadi on pregnancy and the test that they need to do, and then besides that kita sepatutnya kena bagi information regarding HIV, and this actually can be given as group counselling or with the use of brochures or pamphlets. Okay? And so kalau ikut WHO, so the consent jadi untuk ujian saring HIV, it can be a verbal one, a verbal consent. But however, since we are getting written consent from these ladies, jadi untuk melakukan ujian-ujian darah yang lainnya, jadi kita macam boleh ambil one shot lah. Jadi maksudnya bila kita ambil written consent untuk buat ujian-ujian antenatal yang lain, so one shot it will cover the consent for HIV testing. Jadi, and when we talk about consent, jadi untuk melakukan ujian saring HIV, so we are doing what we call opt-out. We are going for opt-out consent. So I will explain further in my next slides. Okay. Jadi, jadi when we talk about HIV testing strategies, basically there are 3 strategies. So one is what we call opt-in. Opt-in maksudnya jadi kita tak make it sort of mandatory. So mungkin kita boleh kata kat ladies tu, oh you can let me know or you can let the doctor know if you would like a test today. Okay? Jadi kalau you nak buat ujian HIV, you boleh beritahu doktor atau beritahu nurse. Jadi secondly, what we call active choice. Maksudnya kita bertanya kepada klien kita, would you like to have an HIV test today? Okay? Dan kajian daripada banyak research menunjukkan, jadi when we go for opt-in ataupun active choice for HIV testing, so the testing tends to be suboptimal, and dan apa nama? So this is an HIV infected children continue to be born. Okay? Jadi kalau kita opt for the first 2 HIV testing strategies. Jadi thirdly, what we're doing in our countries and as what is suggested by the WHO is opt-out HIV testing. Maksudnya, jadi kita sarankan ibu itu, jadi untuk mengambil ujian saringan HIV, you will be tested unless you decline. Okay? Jadi, so before we go for opt-out approach, what is important is patients should be informed jadi that HIV test will be included in the standard preventive screening test and they may decline the test. Okay? Jadi mereka ada hak untuk tidak melakukan ujian. Jadi information ni kita boleh kasih sama ada secara group discussion. Jadi sebab kita sedar jadi antenatal clinic memang kita ada ramai ibu-ibu datang, jadi impossible jadi untuk melakukan jadi one to one untuk provide one to one HIV information. So this can be this information can be done as a group discussion ataupun secara brochures jadi ataupun literatures. Okay, right. And healthcare providers must be certain that the objectives, the risks and the benefit of the strategy are explained to their patients and that the woman understand their right to refuse the test. And however, So if they refuse the test or if the test turned out to be positive, they should not be denied prenatal or obstetric care, and they should not be discriminated against in other ways. Okay. So, and if the patient refuse to do the test, okay, jadi so sepatutnya kita jangan just let go. Bukan kita cakap just tulis dalam buku tu, oh patient refuse. Sepatutnya kalau ada ibu yang reluctant atau refuse to do HIV testing, so this group of ladies, they must be provided with a longer session of counselling, which starts by letting them express their concerns and reasons for objection to the test, so you can address their specific questions and worries. Okay? But so far, as Dr. Anita said, so far none of our mothers have refused or have rejected HIV testing in pregnancy. Okay? And selalunya kalau ada barriers, kalau ibu tu opted out, refuse, so this usually almost always get to do with stigma, discrimination and fear. Maksudnya mungkin ibu ini adalah ibu yang berisiko, jadi dia worry, mungkin dia dijangkiti oleh HIV dan dia bimbang jika kata jadi kalau aku betul-betul positif, jadi nanti apa pula nurse kata, jadi mungkin aku tidak dibenarkan datang klinik, bla bla bla. So they have all sorts of internal stigma. They're worried about discrimination and they're worried about fear of being labeled as HIV positive. So that's why some of the people, they prefer not to know the status, and we need to address all these barriers. Okay, so basically jadi for HIV screening in pregnancy, so again what CDC recommends, this should be done as a universal opt-out screening. So the timing of HIV testing should be as early as possible and it should be at every pregnancy. Okay, jadi katakan ada ibu tu dia pregnant 2 kali setahun, maksudnya in January her UPT was positive and dia datang booking, and then somewhere in November she's pregnant again, so kita kena buat HIV testing at every pregnancy. And jika sekiranya ibu tu datang during labour, still kita test mereka jadi during labour, and if they refuse, as I said earlier on, we need to address the reasons for declining the test. Dan pada ibu yang berisiko, jadi kita sepatutnya repeat the HIV testing after the window period, jadi ataupun in the 3rd trimester, jadi in certain circumstances. Okay, right. So so that's with early detection. Yeah. So when we talk about screening, jadi jadi bila kita dah explain jadi mengenai ujian salinan HIV yang akan dilakukan, jadi kita minta sama ada verbal ataupun written consent. Jadi dan sepatutnya kita terangkan kepada ibu itu jadi mengenai prosedur ataupun jadi bagaimanakah ujian salinan dilakukan. Okay? Jadi kita sepatutnya beritahu, jadi puan, nanti kita akan cucuk jari anda sedikit, ambil setitik darah dan letakkan di atas test kit. Kita akan tunggu untuk 10 hingga 15 minit. Jika ada satu garisan yang keluar, maksudnya anda tidak ada HIV. Jika ada 2 garisan keluar, most likely anda dijangkiti HIV dan anda perlu menjalani ujian konfirmasi. Okay, right. So and then we need to update the result in the antenatal book. Jadi even for negative or non-reactive. Okay? Maksudnya kalau kita ada ibu yang berisiko, jadi kita plan jadi untuk repeat HIV rapid test after the window period ataupun in the 3rd trimester. So please update jadi the second result tu jadi somewhere in the book, so that it makes life easier for our colleague dekat labour room when the patient so come during delivery. Okay. And jadi jika sekiranya HIV test turn out to be positive with 2 lines, so we need to do a confirmatory test. Maksudnya kita kena ambil darah ibu itu, hantar ke hospital jadi untuk ujian serology. Okay. Jadi so ini adalah the flow jadi daripada our guideline. Jadi so kita ada ibu mengandung yang hadir untuk pemeriksaan antenatal. Jadi kita beri pendidikan kesihatan. Jadi so kita kasih group counselling, jadi kita provide group information jadi mengenai kepentingan mengenai HIV, apakah itu HIV dan kepentingan melakukan ujian salinan, dan kita minta persetujuan jadi sama ada secara verbal ataupun secara bertulis. Jadi kemudiannya kita lakukan ujian so rapid diagnostic test. So jika sekiranya ibu tu positif, jadi kita perlu hantar darah untuk ujian confirmation, dan sekiranya positif dan jadi kita perlu rujuk kepada FMS jadi and subsequently be started on treatment. Tapi sekiranya ibu ujian salinan HIV itu negatif, dan kita kena assess the risk factors. Jika sekiranya ibu itu tidak berisiko, jadi kita dokumentkan keputusan HIV rapid test ni sebagai negatif di dalam buku antenatal. Tetapi jika sekiranya ibu itu berisiko, jadi as I said, jadi we need to repeat again. Jadi the HIV testing, jadi after the window period, jadi maksudnya contohnya kalau kita ada ibu yang drug users, jadi kita dapat maklumat bahawa ibu ini adalah menggunakan jarum suntikan. Jadi kalau dia kata, oh last saya share jarum adalah last week, jadi mungkin kita akan panggil ibu ni balik after 4 to 6 weeks untuk repeat balik ujian rapid testnya. Okay. Right, dan jika ujiannya positif dan kita kena confirm dengan HIV rapid test. So for HIV, for high risk mothers, so this includes those women jadi whose past or present sexual partners were HIV infected by sexual or intravenous drug users, ataupun women seeking treatment for sexually transmitted infection, ataupun kalau ibu itu adalah seorang commercial sex workers, ataupun jika ibu itu ada history of past or present history of intravenous drug use, ataupun wanita yang ada history of blood transfusion before 1986, ataupun jika ibu itu ada unprotected vagina or anal intercourse with more than one sex partner. Okay. So jika sekiranya jadi ibu ni kalau kata suaminya adalah drug users, jadi ibu tu mungkin dia boleh tahu, jadi dia sedar suami dia berisiko dan dia juga berisiko dia dapat HIV. The same thing kalau ibu tu ada sejarah for example multiple sex partners in the past, ataupun juga seorang sex workers kan, so the woman knows that she is at high risk and she can volunteer information to us in the antenatal clinic. However, so the problem is, so when we look at our latest data 2020, so almost more than half of our newly diagnosed HIVs are either sama ada MSM, men's sex men, ataupun bisexual. Jadi kita ada banyak jadi lelaki dekat luar sana yang bisexual ataupun gay men, and mereka mungkin ada isteri dekat rumah, jadi mereka juga mungkin jadi heterosexual with multiple partners, jadi in which isteri itu tidak tahu jadi risiko suami mereka. Jadi macam mana ibu ni nak beritahu, nak inform jadi kita dekat klinik bahawa mereka berisiko sedangkan mereka tidak sedar aktiviti husband mereka jadi outside the house. So that's why so some states I believe, so they are repeating again HIV rapid test jadi at 36 weeks for all pregnant women. Okay, I think this is a fair reason jadi giving these statistics that more than half jadi of our HIV infected patients are either gay men ataupun bisexual, in which the ladies, so they do not realize or they do not know about their husband's extracurricular activities. Right. So jadi bila kita dah buat screening, jadi if the test turn out to be positive, then we need to proceed with confirmatory test. So jadi kita cakap dengan ibu itu, jadi nampaknya unfortunately jadi result rapid test anda ada 2 garisan, maksudnya most likely anda ada HIV, jadi kita perlu hantar darah awak untuk confirmation. Jadi bila kita hantar darah ke HKL, for my clinic we send to HKL, jadi for other states so you can send to your respective hospitals. Jadi kalau kita tulis the PEP form clearly, contohnya kita tulis jadi so patient came for antenatal visit, noted HIV rapid test positive, please do confirmatory testing. Jadi jika sekiranya jadi kita tulis kita volunteer all these informations, usually jadi our pathologists, our colleagues in the pathology department, they won't ask a second sample because jadi the HIV rapid test, the positive HIV rapid test is already considered as the first positive sample. Okay, jadi maksudnya so untuk kita confirmkan status HIV, kita perlukan 2 result positif, and salah satu result itu it can be from our HIV rapid test. Okay, jadi so if you write it clearly on the PEP form, jadi HIV rapid test positive, and serology test, in this case in my referring hospital they did CMIA and particle agglutination test. If both the tests are positive, so usually our pathologists they would not ask for a second sample. Okay, right. So what is important, I believe you need to know your lab's turnaround time. Okay, so you need to communicate with your virologist. Okay? Jadi Contohnya, jadi kalau kita ada especially ibu yang late bookers, jadi kita kena inform our virologist, look, jadi sorry doctor, jadi we have this lady coming late for booking, the HIV rapid test is positive, so the name is so and so, IC is so and so, jadi so can you run the test ASAP. Okay? Jadi sebab kalau kita nak tunggu result balik, it will take around 1 to 2 weeks, and jadi time matters, especially in late bookers. Jadi kita perlukan result confirmation awal so that the FMS can start treatment early. Okay, right. So, jadi bila kita dah dapat result positif, dan we need to give counselling for the HIV positive mothers, and counselling need to be a continuous process. Okay, jadi bukannya one off. So every time jadi ibu ni datang jadi untuk visits, so we need to reinforce HIV awareness. Okay, jadi kalau ikut Datuk Fazilah Kamsah, dia kata, jadi information need to be delivered at least 200 times. Jadi baru boleh melekat dekat kepala otak. Jadi you imagine kalau first time ibu tu detected positif, kita cerita satu-satu fakta mengenai HIV. Jadi dalam keadaan ibu tu jadi probably in denial, jadi probably tak sampai separuh information yang sink inside the mind. Okay? Jadi so we need to give continuous education jadi at every visit. Okay? Jadi, so we need to stress on the importance of adherence to treatment, so the delivery, so later on about the infant feeding, and of course the need for spousal testing. And we need to inform these mothers that we need to notify jadi their case to KKM. So what I normally tell them, Puan, jadi semua maklumat yang diberikan adalah kerahsiaan, tetapi adalah menjadi tanggungjawab saya untuk melaporkan kes Puan kepada Kementerian Kesihatan. So, jadi ini adalah untuk tujuan statistik, dan semua maklumat yang diberikan jadi adalah confidential, akan tetapi jadi mungkin Inspektor Kesihatan akan call you jadi untuk to verify. Jadi kita harap jadi Puan dapat beri kerjasama jika menerima jika dihubungi oleh pihak Inspektor Kesihatan ataupun PPKP. Okay, so we need to inform this to them beforehand so that they know what to expect. Jadi otherwise they might be quite upset. Jadi mungkin mereka kata, oh nurse kata tadi confidential, tapi entah siapa-siapa call mengaku sebagai Inspektor Kesihatan, and so they might start be worrying about their confidentiality issues. Okay? Right. So, jadi maklumat untuk ibu mengandung mengenai HIV, it can be in the form of brochure, jadi or pamphlet, or continuous education delivered by our health workers jadi during each visit. So, this is an example jadi of one of the pamphlet. So, to me this is quite worthy. Jadi mungkin ibu baca 2 baris pun mungkin dah fed up. Jadi mungkin kita kena letakkan gambar-gambar sikit bila kita buat pamphlet, so to make it more interesting. Okay, right. So then, jadi all antenatal mothers, jadi bila kita dah dapat result confirmationnya, jadi then they need to be referred to FMS as soon as possible. Jadi after confirmation for initiation of ART, for confirmation of diagnosis, they need to be referred. Jadi after confirmation of diagnosis for ART initiation, okay? And later on they need to be referred to combined clinic and in the hospital. For those mom who are late presenters, after 28 weeks, so we need to refer them to our ID physician for tenofovir and ampicillin plus ratigrapil regimen. Okay? And it's good to refer them to NGOs or caseworkers or peer, so for social and emotional support. Okay, right. So that's about the flow. Yeah, for antenatal mothers who come, for HIV testing among antenatal mothers. Okay, so the next question is, jika sekiranya ibu itu HIV positif, when is the optimum time to initiate antiretroviral treatment? So if you look at latest BIVA guideline, so they suggested that the timing for combined antiretroviral treatment, it should be based on the viral load viral load level. Okay, so the BIVA guideline suggests, so all women who are not yet on ART should be started on treatment as soon as they're able to do so in the second trimester, where the baseline viral load is less than 30,000 copies per mil. Okay? And jika sekiranya ibu tu mempunyai viral load between 30,000 to 100,000 copies per mil, jadi the treatment should be started either in the second trimester or as soon as possible thereafter. Tetapi for ibu yang highly viremic, maksudnya the viral load baseline is more than 100,000 copies per mil, ataupun jika CD4 ibu tu is less than 200 cells per millimeter cube, maksudnya ibu tu in the 8th stage. So in this group of ladies who are highly viremic and who are in the 8th stage, so treatment can be started within the first trimester itself. So in and out, jadi all women should be commenced on combined ART by 24 weeks of pregnancy. Okay, so what to give? So the regime is actually similar to non-pregnant patients. So women are recommended to be started on tenofovir and tricitabine. So the generic that we have in our clinic is Tenof-M combined with efavirenz. Okay, 600 milligram once daily. Okay, so how long is the treatment? So we are currently moving towards option B+. Option B+ means, so jika sekiranya ibu ni baru diagnose HIV in pregnancy, so we start them on ARV and they have to continue the treatment lifelong. So walaupun baseline CD4 dia masih lagi okay. Maksudnya kalau at baseline CD4 ibu ni contohnya adalah more than 500, 600 ke 800 ke, jadi kita suggestkan ibu ini untuk continue treatment, jadi lifelong dan tidak stop, jadi after pregnancy. Yes, right. So basically, we have 3 categories of mother, jadi yang kita detect ada HIV dekat antenatal clinic. So one is newly diagnosed mothers who are not yet on treatment, and then we have mothers who are already diagnosed before they get pregnant, are already stable on medication. And the third group is ibu yang tidak ada antenatal follow-up and they are only diagnosed in labor with no prior therapy. Okay, so let's go one by one. Okay, so for HIV positive mothers who are newly diagnosed during the antenatal visit and they are heart naive, maksudnya mereka belum lagi distartkan rawatan. Jadi what we need to do to them, jadi kita kena beri counselling. And then we need to start them on antiretroviral treatment regardless of the CD4 count. Okay, so when to start? Jadi kita dah discuss tadi, it actually depends on the viral load level, but in and out, jadi by 24th weeks of pregnancy, they should be on ART already. Jika sekiranya ibu ni datang lewat, so either late bookers, jadi after 28 weeks, then we need to refer them to our ID colleagues for ratigrapir based regimen. Jadi why ratigrapir? Because many studies have shown that ratigrapir it is more effective than efavirenz at reducing the viral load to less than 50 copies by 36 weeks gestation. Okay, and then we need to do viral load tests between 32 to 36 weeks of pregnancy. So if the viral load is well suppressed at less than 50 copies per mil, ibu-ibu ini jadi boleh dibenarkan for spontaneous vaginal delivery. However, if the viral load is not well suppressed by 32 to 36 weeks, so we would advise them for a lower segment cesarean section and they should continue ART post-delivery. So untuk ibu yang memang dah lama diagnose HIV, they are already on treatment prior to pregnancy and then they get pregnant and come to see us. So we need to have the latest viral load result. So jika sekiranya ibu ni stable on heart, that means the viral load is less than 50 copies before pregnant, then so still we need to give our counselling. So tell them to continue with their ART treatment. Then we do viral load again at 32 to 36 weeks. And so if the viral load remains stable, so they could deliver their baby vaginally and they should continue post-delivery. But for those who fail treatment, maksudnya at the beginning of pregnancy, the viral load is more than 1,000 copies. Jadi after treatment initiation for at least 3 months, then they need to be referred to our ID physician and we need to alert so the ID pediatrician or the general pediatrician, because in this group of women, their babies are at high risk of vertical HIV transmission. And then usually our ID colleague will do resistant testing, and this group of women would be suggested for lower segment cesarean section at 38 weeks, and this will be discussed further, yeah, jadi tomorrow. Okay. So for women who do not have any antenatal check and they only presented themselves in labor, and rapid tests during labor turn out to be positive, so they will be given IV sidovudin during labor, and then usually so they will be started on 2 NRTI, usually tenofovir and presitabine plus ratigrapir. If the hospital does not have ratigrapir, then they will be given efavirenz or nevirapine immediately, and subsequently they will be switched to the recommended first line regimen post delivery, and this will be dealt with in further detail by our MFM colleague tomorrow. Okay, so for all these mothers, jadi during antenatal check, jadi during antenatal follow up, kita kena emphasize ke ibu ni mustahaknya untuk deliver di hospital yang ada ONG specialist and pediatrician. Maksudnya ibu ni sama sekali kita tidak boleh suka-suka nanti jadi bila dekat-dekat nak deliver tiba-tiba balik kampung dan sakit, and as unplanned delivery dekat sambil-sambil hospital district, tak boleh. Jadi kita kena emphasize, jadi anda ada HIV, jadi anda perlu deliver in so just hospitals yang cuma ada jadi ONG and pediatric specialists, and their babies must be referred to ID physician or general physician as high risk cases. Okay. And ibu ini juga actually as part of the counselling, jadi we need to inform them jadi that sesiapa kelahiran, jadi mereka tidak boleh bawa balik uri jadi so the placenta so need to be managed in hospital, jadi so they cannot bring the placenta back. Okay? That should also be mentioned jadi somewhere during our counselling process. Okay, right. So for infant feeding, jadi so walaupun ibu ini virally suppressed, jadi usually so almost always we advise them on formula feeding. Okay, because walaupun viral ibu itu undetectable, this is not equivalent to untransmittable. This is not equivalent to HIV not being transmitted to breast milk. Okay, jadi still jadi ada a small risk of vertical transmission via breast milk even though mom is receiving antiretroviral treatment. Jadi kita must stress to the mother the importance of formula feeding, dan jadi kita so ibu adalah entitled jadi untuk dapat free infant formula jadi for babies jadi up until the baby is 2 years old. Okay. And jadi sebagaimana ibu-ibu yang lain, jadi kita sepatutnya pada ibu HIV positif juga kita kasih counselling and education jadi about breast care, so ensure environmental sanitation and good hygiene during preparation of the infant feeding. Okay. And jika sekiranya because kita tidak mahu ibu ni breastfed, jadi some of them jadi might have breast engorgement, jadi kita kena kasih appropriate advice on breast care, and jadi if needed, so MOs need to prescribe them with lactation suppression therapy, contohnya ubat bromocriptine jadi untuk stopkan breastfeeding. Okay. Jadi despite jadi kita beri advice pada ibu jadi breastfeeding tidak digalakkan, jadi mungkin kita akan encounter ibu jadi yang insist on breastfeeding. Okay. Jadi ibu ni pelik sikit jadi bila kita suggestkan contohnya imunisasi, some against tak nak jadi anak-anak mereka terima vaksin. Tapi bila kita suggestkan jangan bagi breastfeeding, jadi mereka nak juga breastfeeding. Jadi contohnya to go for the natural way, and so I believe jadi what we need to do is so kita tak boleh kata tak boleh jadi sebab again it goes for human rights. So what we need to do is so we need to give informations, jadi kita beri maklumat-maklumat so that ibu-ibu ini jadi dapat membuat informative decision sama ada nak continue breastfeeding atau tidak. So we tell them, so look, jadi no doubt jadi you punya viral load dah well suppressed, tetapi kalau according to research, ikut data yang kita dapati, jadi walaupun dia punya viral load dah rendah, tapi still there is a small risk of viral transmission, HIV transmission through your breast milk. Jadi kalau kata ibu tu insist juga nak breastfeeding, so the mother and the child need to be seen by pediatrician first. Okay? Jadi sebelum kita dekat KK ni approvekan mereka untuk breastfeed. And then secondly, they need to have this lady need to have a healthy breast. Maksudnya mereka tidak ada cracked nipple, tidak ada ulcer ataupun abscess, tidak ada mastitis pada breast mereka. Because kalau mereka ada keadaan-keadaan macam ini akan meningkatkan lagi transmission of HIV through the breast milk. And we must make sure that the maternal viral load is consistently less than 50 copies per mil. Okay? Jadi masalahnya, jadi ujian viral load kita ada limitations, ya. Jadi kita tak boleh buat kerap. Okay? Jadi, so for example, jadi in KL we are only allowed to do viral load once a year. So because of the budget limitations, ini adalah untuk ibu yang well suppressed. So we can only do once a year viral load testing. Jadi untuk ibu ni mungkin kita kata, so you need to do viral load more frequently, probably something like every 4 months kalau you insist nak breastfeeding. Tapi sebab kita cuma boleh buat viral load dekat hospital ni once a year, jadi mungkin you kena buat sendiri. Kita boleh tolong ambil darah you dan outsource to private lab. And usually in my clinic, when we outsource to Gene Flux lab, the cost is around RM350 per test. Okay? And the same thing, so infant juga jadi kena buat monthly PCR test more frequently than the schedule, jadi until the breastfeeding stop. Okay? Jadi so and then we advise the mother, jadi kalau nak breastfeed juga, jadi so this should be exclusively breastfeeding. Yeah? Jadi is recommended instead of mixed feeding. Okay? Jadi kenapa? Sebab kalau mixed feeding, sekejap bagi breast milk, sekejap kasih bottle feeding, jadi there is higher risk of breast congestion. Jadi bila ada breast congestion, higher risk of mastitis, cracked nipple, and so this would increase also the risk of transmission of the virus vertically, through the breast milk. Okay? Meaning, jadi bila kita explain ni, jadi kita make it sort of inverted comma, make it more difficult. Okay? We make the option more difficult for the mother. Okay? Jadi so we explain the mother the criteria. Jadi with all the information that we give, so kita harapkan ibu ni dapat membuat an informative decision, yes, sama ada nak meneruskan breastfeeding atau tidak. Okay, kita sama sekali sepatutnya kita tidak katakan tidak boleh, jadi full stop, sebab then the next thing they will go to Suhakam and complain, jadi about their rights being denied by the healthcare providers. Okay. Okay, next home visit. Jadi home visit untuk ibu HIV positif, jadi basically adalah sama sahaja macam mana postnatal visits, antenatal or postnatal visits untuk ibu-ibu yang lain. Jadi an extra thing probably is we need to check on ART adherence, jadi and side effects. Check on the mom's compliance on follow-up schedules. Yes, sebab mom lepas delivery especially, bukan saja ibu saja yang ada appointments, follow-up schedules dengan FMS ataupun dengan ID klinik, tapi anak juga, baby juga akan ada follow-up appointments dengan pediatricians. Okay, right. So when we talk about family planning, so as Dr. Anita mentioned earlier on, jadi BTL is not mandatory, so it is only done when medically indicated. Contohnya kalau mother ada heart problem, and decision should be made by medical or IB and ONG specialists. Okay? And for hormonal contraceptions, so there might be possible drug interaction between OCPs and both NNRTIs and protease inhibitors, thus making the contraception less effective. Maksudnya, contohnya kalau kita nak beri, nak cadangkan apa, contohnya Rigividon ke pada ibu yang ambil Tinof-M and efavirenz. So OCPs tidak mengganggu keberkesanan ubat heart, tapi ubat ART ini yang mungkin akan ada menunjukkan interaction dan menyebabkan contraceptives kita menjadi less effective. So the options, the preferred contraceptions for HIV positive mothers are either depo, implant ataupun IUD. Okay? Jadi, and we need to emphasize them again and again on correct and consistent condom use. Okay? So I believe Dr. Muniz will elaborate more about family planning tomorrow. Okay? So So jadi bila ibu datang postnatally, jadi untuk vaccination, jadi so we must ensure jadi adherence of make sure that the mom memberi rawatan prophylactic kepada baby, adhere to the prophylactic treatment of sirocidobulin or sirabactrin. So we need to look for opportunistic infection in the child. So look for the presence of neck nodes, jadi of oral thrush. So vaccination should be as scheduled, and so kita kena update child's HIV status jadi based on the PCR results. Okay, and we need to ensure the mother that the mother or the caregiver comply with the pediatric follow-up appointments. Okay, so last but not least, so it's good to refer all these positive mothers jadi to other disciplines jadi as required, contohnya to dietitian ataupun social workers. Jika ibu ni adalah substance abusers, so we can refer them to the substance abuse agencies such as our methadone clinic ataupun CMC colleagues. And it's also good to refer them for peer support. Jadi contohnya kalau dekat KL ni kita ada, contohnya kalau ibu yang ada poor social support, jadi abandoned by the family ke ataupun single mother, so we can refer them to Rumah Salihah jadi ataupun to this group called Perwahim. Jadi so they are doing actually good job for our women living with HIV. And because sometimes ibu-ibu ni bila kita nasihatkan mereka, mungkin ibu ni akan kata, jadi nurse ni, doktor ni boleh dah cakap, dia orang cakap ikut buku saja. Jadi so but when they listen to somebody living with HIV with their peers, so they will accept better. Okay, jadi and studies have shown that so peer interactions dapat mengurangkan internal stigma. Okay, jadi within jadi people living with HIV. Okay, jadi I think that's all. Jadi this is my friend jadi Puan Nolela. So she is actually the pioneer of this Wahim group, and dia pun ada actually rumah shelter home dekat Bukit Beruntung. Jadi for women, for single mothers or women who has problems, who has social issues with regards to HIV. Okay, so so that ends my talk. Jadi thank you very much for the attention.
Thank you very much, Dr. Narul, on the updates. Very well, very informative. We will go ahead and take some questions, take some time for questions now. Dr. Narul can also look at the WebEx chat box for the questions. Just a reminder, please be sure to submit your questions at the question link at the YouTube description or the WebEx chat box. So you can ask in English or Malay. Cakap Melayu, tulis Melayu pun tak apa, tanya soalan, kita pun jawab juga. Jangan risau. So for our first question, we can look at the WebEx chat box, Dr. Narul. So the first question is, nanti jap, from Goh Suli. The CPG encourages dual contraception, yet we are promoting U equals to U. Why should condom be there if mother is having undetected viral load and both mother and her husband is no more having high risk?
Okay. Yes, it's correct. We are promoting U equals to U. So for those who are not familiar with the concept of U equals to U, it means that if the person's viral load is undetectable, jadi this is equivalent to untransmittable. Jadi that means so the person won't be transmitting the virus to the partner. Jadi if her viral load, her or his viral load is undetectable. So I guess yeah, the reason first of all for contraception is we want to space the pregnancy. Okay, and so yeah, I agree. So with statement why double contraception? Jadi I've been looking around for the answers but could not find it. So yeah, contraception is basically to promote, to space out the pregnancy, and yeah. So and yes, the idea of contraception is probably some of these mothers, as I said, they do not realize the husband probably is still in the highest risk group. For example, husband might be having his sexual activities, might have undetected syphilis or other STIs. So condom is not just for prevention of HIV transmission, but it's also for prevention of other STIs. So yeah, Basically, that's the idea of condom use. Okay? Right. So,
Okay, doctor. So we go to question 2, yeah, from Dr. Izzat. How common in your practice mothers in Malaysia refuse HIV testing in pregnancy?
so as Dr. Anita mentioned in her talk, so far we are not seeing mother who refuse. Okay, jadi HIV testing is not been reported to her unit. But if that happen, so as I said, the most common reason is fear of knowing status and fear of stigma and being discriminated. Okay, so that's why if a mother refuses HIV testing, then we need to explore the reason and we need to give to it more counselling. Jadi need to provide more information regarding testing and the need, why there is a need for testing and more information about the risk of HIV should the person have it, risk of transmission to the baby. Okay.
Okay, thank you, Dr. Narul. And the last question for Dr. Narul for today is from Masini Abdul Aziz. What about patient agreeing for testing, but when positive for HIV, patient requests us, in the KK level, for not to write the HIV result in the antenatal book, buku A, because afraid of other family members will know about it.
Yes, I think so. We healthcare providers, yes, we should be sensitive on this issue. Okay, jadi a few years ago, jadi actually I have encountered this problem. Yeah, so patient saya ni, so she has long been with me, and then she gets pregnant, and then so she went for antenatal check at the nearest KK to her housing area. So she was telling me, Doc, so dekat buku antenatal saya tu tulis faktor risiko dengan pen merah pula tu, HIV positif. Saya jaga buku tu macam jaga emas dekat office, saya letak dalam locker. Problemnya bila dah postnatally, so she has spent her pantang with her in-laws, so dia tak tahu nak letak buku tu dekat mana, so pity the mothers lah. So what I have been suggesting, so when I give talks on PMTCT, mungkin kita we should avoid tulis HIV positif dengan pen merah sebesar-besarnya dekat penjuru kanan atas buku tu. So probably we should write something like what PMTCT ke atau EMTCT ke, so ataupun letak code ke, jadi so that so we should be more creative lah, so to communicate the information to our colleague, mungkin the word EMTCT ke rather than HIV. Okay, ataupun kalau you takut orang di other side dekat hospital tak faham ke, mungkin at least write RVD ke. At least RVD tidak banyak sangat implikasinya compared to HIV. Okay? Jadi so we should try as much as possible jadi untuk jaga patient punya confidentiality. Because walaupun nampak kecil pada kita, mungkin ini adalah salah satu faktor di mana ibu tu refuse untuk datang. Okay? Jadi untuk continue follow up dengan kita. Okay? Jadi because they worried about their confidentiality issues. Okay? Jadi to answer the question, either write something else, either RVD ke ataupun EMTCT ke PMTCT ke. Jadi so as a way for us to communicate jadi with other colleague kat hospital during delivery tu lah. Yeah.
Okay, Alhamdulillah. Thank you, Dr. Narul, for your presentation and also explanation for the Q&A session. I think that wraps up for Dr. Narul's session. If there's any more questions, we will answer for email due to time constraint. Okay, Dr. Narul, thank you. Thank you very much.
Thank you very much.
Okay. Now, let's move on to our second topic of the day, which is updates on management of syphilis in pregnancy, during antepartum and postpartum, importance of early and adequate treatment. Dr. Nik Mazlina will give the presentation. Dr. Nik Mazlina Muhammad is a family medicine consultant, currently working in Klinik Kesihatan Kelana Jaya. She graduated from University Malaya and later pursued her master's degree in University Kebangsaan Malaysia. Dr. Nik has more than 20 years experience in primary care and is actively involved in training and also research. She sits in the National Committee for the Confidential Inquiry into Maternal Death and is a panel member of the National AMTCT and Congenital Syphilis Committee. Her clinic is actively involved during the MTCT validation in 2018. Thank you, Dr. Nick. You may proceed. The floor is yours.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all present. Thank you very much, Mr. Chairman, for the kind introduction. Before I begin, I would like to thank the organizing committee for inviting me to present in this morning's webinar. So for this morning, I'll be presenting on management of syphilis in pregnancy at the primary care level, importance of early and adequate treatment. Okay, so this is the outline of my presentation. I will start off with understanding syphilis, followed by syphilis in pregnancy, antenatal screening for syphilis in primary care, treatment, postpartum care, and monitoring. So what is syphilis? Syphilis is an infectious disease caused by Treponema pallidum. The incubation period for syphilis may vary from 9 to 90 days. It may be transmitted through sexual contact with infectious lesions of the mucous membranes or abraded skin, via blood transfusion, or transplacental from a pregnant woman to her fetus. So syphilis may be acquired or it may be congenital. In acquired syphilis, we may classify syphilis as early syphilis if the infection is less than 2 years, or late syphilis if the infection is more than 2 years. Early syphilis constitutes primary, secondary, and also early latent syphilis, whereas in late syphilis comprises of tertiary syphilis. Likewise, in congenital syphilis, there is also early congenital syphilis if the infection is less than 2 years, and late congenital syphilis if the infection is more than 2 years. Okay, in terms of infectivity, primary and secondary syphilis is the most infective stage of syphilis. In latent syphilis, patients are usually asymptomatic and not contagious. However, in this stage, pregnant women can still transmit the disease vertically to the fetus. Tertiary syphilis is the most destructive to health. Okay, let's go through primary syphilis. Primary syphilis is usually characterized by syphilitic chancres. These chancres are usually painless. It's indurated with a clean base, highly infectious, and may occur anywhere on the body. Because of its painless nature, some patients may not realize that they are having chancretic ulcers. It may be associated with regional lymph adenopathy, which is classically rubbery, painless, and bilateral. Serologic tests for syphilis may not be positive during early primary syphilis. Okay, so this is where some of the chancres may present in the penile area, labia, perianal, or even the tongue. Okay, secondary syphilis is a stage of bacteremia. So most serological tests are usually highest in titer during this stage. RPR titers in untreated cases are often more than 1 in 8. So during secondary syphilis, most patients will present with signs and symptoms. Okay, the most commonest signs are usually the skin eruptions. More than 95% may have macular papular or annular rash, usually in the palms and soles. They may also have moth-eaten alopecia and may have oral erosions in the mucous membranes and also condylomata lata. Some may present with systematic symptoms which may be vague in nature: malaise, anorexia, headache, sore throat, arthralgia, fever, and generalized lymphadenopathy. Okay, so these are some of the rashes that may present in secondary syphilis. Okay, most commonly it will occur in the palms and soles. Okay, condylomata lata and also moth-eaten alopecia. Okay. Secondary syphilis is followed by an asymptomatic stage with no clinical findings but with a reactive serologic testing. It can be divided into early latent in the first 2 years of infection, and it can also be late latent. That is, if the infection is more than 2 years duration. In late latent syphilis, patients are usually not infectious but can be transmitted by a pregnant woman to her fetus. Patients who have latent syphilis of unknown duration should be managed as if they are in late latent syphilis. Okay, tertiary or late syphilis is not contagious, but they are highly destructive phase, which may take many years to develop. There are 3 forms of tertiary syphilis, which is late benign or gamma syphilis, cardiovascular syphilis, and also neurosyphilis. Okay, now that we have gone through the different stages of syphilis, let's go into syphilis in pregnancy. As mentioned earlier, syphilis can be transmitted transplacentally from a pregnant woman to her fetus. Transmission can occur during any stage of syphilis, but the risk is much higher during primary and secondary syphilis because this is the stage where syphilis is most infectious. Transmission rate to the fetus can be as high as 95% in untreated mothers with primary or secondary syphilis. Fetal infection can occur during any trimester of pregnancy. The fetus can be easily cured with treatment, and the risk of adverse outcomes to the fetus is minimal if the mother receives adequate treatment during early pregnancy. So ideally, our mothers should be treated before the second trimester. Elimination of mother-to-child transmission of syphilis can be achieved through implementation of effective early screening and treatment strategies for syphilis in pregnant women. These are some of the adverse pregnancy outcomes that may happen in syphilis: polyhydramnios, miscarriage, 3-term labor, stillbirth, high drops, IUGR, and congenital syphilis. In order to prevent adverse pregnancy outcomes, therefore, it's very important for us to diagnose syphilis early in pregnancy and institute adequate and effective treatment. Therefore, we need to screen for syphilis in pregnancy. But who among our pregnant women need to be screened? When should they be screened? And how are they screened in primary care setting? So the WHO STI guideline recommends to screen all pregnant women for syphilis during the first antenatal care visit. That means that all our antenatal mothers that come for antenatal booking should be screened for syphilis during their first visit. We have many other tests to diagnose syphilis, but in primary care, these are the tests that is commonly used. In primary care, we use the serological test, which constitutes the non-treponemal test, which is the RPR or the VDRL, and also the treponemal specific tests, which is the TPHA or the TPPA. Rapid diagnostic test is something new in our country, but it has been used in several states. Okay, let's go through the non-treponemal serological tests, which is the VDRL or the RPR. Okay, these tests detect antibodies not specific to treponema pallidum. Therefore, we may get false positive results, for example, in HIV, autoimmune conditions like lupus, pregnancy itself, injection drug use, and certain types of pneumonia. Level of antibody is measured in titer. So when you do a non-treponemal test, the results will come back as in 1 in 2, 1 in 4, 1 in 8, so forth and so forth. It is useful in monitoring treatment for syphilis. It can be monitored periodically and it should decrease. The titers should decrease after treatment and become negative about 2 to 3 years after proper treatment. Okay, treponemal serological test constitutes the TPHA or the TPPA. This test detects antibodies specific to treponema pallidum. Therefore, it will confirm the VDRL or RPR results and is confirmatory for the diagnosis of syphilis. TPHA or TPPA will remain positive lifelong with or without treatment, and therefore it is sometimes called leaving a serological scar. Okay, in rapid diagnostic test, is actually syphilis antibody rapid immunochromatographic test. It uses serum, plasma, or you can even use whole blood. It is useful in the following situation or patients: in high-risk mothers, in late antenatal workers, more than 28 weeks period of gestation, hard-to-reach population, for example, our orang aslis or those who are living in the interior in Sabah or Sarawak, or in KKIA or clinic desa with no lab facilities to do RPR or VDRL. Okay, so how do we interpret the serology test? VDRL or RPR positive and the TPHA is negative. The interpretation is that it's usually a biological false positive and we may repeat the test if early syphilis is suspected. If the VDRL or RPR is positive and the TPHA is also positive, then we diagnose syphilis or it may be recently treated syphilis. If VDRL or RPR is negative, non-reactive, and the TPHA is negative, then there is no evidence of treponemal infection. May repeat if there is risk of recent infection. If the VDRL is negative and the TPHA is positive, then it may be late latent syphilis or treated syphilis. So this is an example of test result that we may receive in the klinik kesihatan. Treponema pallidum particulate agglutination, TPPA, is positive and the RPR test is reactive with a titer of 1 in 128. So flow of antenatal screening for syphilis in primary care. We now have two flow on how we screen our antenatal patients in KK. Firstly is the standard screening strategy, which is lab-based, and the second flow would be a screening strategy using rapid diagnostic test. So let us go through the flow for the standard screening strategy, which is lab-based. Okay, so when our antenatal mothers come for their booking or antenatal booking, so what happens is usually our nurses will give a health education or counseling on what sort of blood tests will be taken. Okay, so they will explain to the patient what type of blood test will be taken, why do we need to do the blood test? What are the implications if the test turns positive? And usually a signed consent will be taken from the mothers. Okay, so after having the consent, the nurses will proceed with taking blood for the RPR VDRL test. Okay, so this VDRL and RPR test in most clinics can be ready in 1 day. However, in some clinics, if the workload is high, meaning that they are serving a very reproductive age population, or sometimes when there is shortage of MLT, the test may be ready in 2 or 3 days. But generally, in most cases, in 1 or 2 days, the RPR VDRL test will be ready. Okay, so once the RPR and VDRL test is ready, if it is reactive, then what happens is usually the MLTs will alert the nurse in charge of the results, and the nurse will in turn inform the medical officer. Okay, then using the same specimen, the blood will later be sent for TPHA or TPPA to confirm the diagnosis of syphilis. So this blood test, the TPHA or TPPA, is not done in the clinics and will have to be sent to the hospitals. Okay, so once this test is sent to the hospitals, the turnaround time may take as around 5 to a week before it is ready. Okay, so if the VDRL test is non-reactive, then we will need to look back at the clinical history. Is the mother high risk? If the mother is high risk, then we will need to repeat another RPR at 28 or 32 weeks, okay? But if the RPR is negative and the mother is not high risk, then we will continue follow-up, antenatal follow-up as usual. Okay, so once the TPHA comes back and it is positive, then the MO will usually discuss the case with the family medicine specialist, and we will institute a treatment for syphilis. And we will also refer the patient to combined care, ONG and ID physician in the hospital, and do a notification and also contact tracing. Okay, so this is another flow using the rapid diagnostic test. So as mentioned, the rapid diagnostic test can be used under the following situation. Okay, if we are serving a population that is hard to reach, for example, the orang aslis or the people living in the interiors of Sabah or in Sarawak, in late bookers, for example, patients coming in at already 36 weeks BB, 35 weeks, okay, or in KK or KDs that do not have the facility to do RPR and VDRL, and they have to send to an index KK, which is some distance away to get the test done, and in high risk patients, okay. So in this sort of situation, we may use the rapid diagnostic test. So like the lab-based strategy, before we do the test, we will still give health education, explaining regarding why we are taking such tests, and signed consent from the patient before proceeding with the test. So in this strategy, we do point of care testing, which is the rapid diagnostic test for syphilis, and at the same time, we also take blood for the RPR and also the VDRL test. Okay. So once you do the rapid diagnostic test, if it is negative, then you will look back into your clinical history. If the patient is high risk, or if the patient is a late booker, meaning that the patient came in maybe at 35 weeks, 34 weeks, okay, then you will need to repeat another test. If the patient is high risk, you would repeat the test at 28 to 32 weeks. And if the patient is a late booker, then you would do the test in another 4 weeks' time. If the RDT is positive, then we would inform the medical officer or family medicine specialist on the same day and institute treatment on the same day. Okay, so after we have institute treatment on the same day, we will also have to trace the RPR results that was taken on the same day. If the RPR test result is negative, then we would continue antenatal follow-up as usual. But if the patient happens to be high risk or a late booker, then the above applies, meaning that we will repeat the RDT again at 28 weeks or 1 month later. Okay, if the RPR is positive, then we will send a TPHA or a TPPA blood specimen to the hospital, and we will also proceed with the second and third dose of penicillin to the mother. Okay, and we should trace the TPHA and TPPA results as soon as possible. And if it's positive, confirmatory of syphilis, then again, we will have to refer the patients to combined clinic in the hospital, notify and do a contact tracing. If the TPHA, then TPPA comes back as negative, then we will manage the patient antenatally as per usual, and most probably it has been a false positive test. Okay, so when we say high-risk mothers, what do we mean by high risk? So mothers who are sex workers, those with history of HIV or STI, history of promiscuity or having multiple sexual partners, or their sexual partners have HIV or syphilis, those with history of abortion or stillbirth, rape case, or history of substance abuse, these would constitute high-risk mothers. And if the initial screening during antenatal booking is negative, then we will repeat the test at 28 to 32 weeks of gestation and again at delivery. Indication for treatment: newly diagnosed syphilis of any stage, we should treat them. Okay, if there is unclear history of adequacy of syphilis treatment prior to pregnancy. Okay, some patients may come to us giving some unclear history, saying that they were informed by so-and-so doctor that they have a sexually transmitted disease. They have been treated, not sure by injection or by oral tablets, whether if injection only 1 dose was given, 2 dose was given, 3 dose was given, what were the titers, they were unclear, unable to give a clear history. So if in doubt, then these patients should be treated for syphilis. Okay, if the titer during the current pregnancy is more than 1.8, let's say it's 1 in 64, 1 in 128, then they should also be treated. If a serology cure did not occur, meaning that we have a baseline, let's say the patient's initial titer was 1 in 64, okay, and it did not manage to drop to 1 in 16, then this is also an indication for treatment. And another indication, if the titer in pregnancy now is higher than the titer before pregnancy, then this is also an indication for treatment. Okay, so how do we treat our patients for syphilis? So as we have gone through earlier, we now know what is early syphilis and what is late syphilis. So for early syphilis, if we diagnose early syphilis, that is primary syphilis, secondary syphilis, or early latent syphilis in the pregnant mother, then the preferred treatment is to give benzathine penicillin 2.4 mega units stat, only one dose. Or you can give procaine penicillin 600,000 units IM daily for 10 days. Okay. If the patient is allergic to penicillin, then we can give rosaphine or erythromycin or azithromycin. I think this will be further elaborated by our next speaker after this. Okay. In late syphilis, that is if the patient has late latent syphilis, gummatous syphilis or cardiovascular syphilis, then the regime would have to be extended for another 3 weeks. So we will give benzathine penicillin 2.4 mega units IM weekly for 3 weeks. Or if we give procaine penicillin, then it has to be given daily for 14 days. Okay, in neurosyphilis, we will have to give benzyl penicillin 4 mega unit IV for hourly for 14 days, or procaine penicillin 2.4 mega unit IM daily, plus probenecid 500 milligrams per oral 6 hourly, both for 14 days. Okay, what is important to note here is that if the patient has got allergic history to penicillin, and is treated with a regime other than penicillin, we will have to document it clearly in the patient's antenatal card so that it serves as a reminder to our colleagues, to our ONG and pediatric colleagues in the hospital. Because other than penicillin, erythromycin or azithromycin, they do not completely cross the placental barrier. Therefore, although it may treat the syphilis in the mother, it does not treat syphilis for the fetus. Okay. So treatment will kill the syphilis bacterium and prevent further damage, but it will not repair whatever damage that is already been done. So after we have instituted the treatment, according to the suitable regime based on our stage of syphilis, then we will repeat the VDRL titer every month until delivery to see whether the patient is showing improvement or not. Okay, patients are expected to show a full reduction in non-treponemal titers in 6 to 12 months. That means after we have treated the patient with the appropriate regime, then our subsequently VDRL titer should show a fourfold reduction in titer. For example, if the baseline titer before treatment was 1 in 64, then after treatment, it should come down fourfold to maybe 1 in 16 or 1 in 4. Okay. We have to consider retreatment if the clinical symptoms or signs still persist or recur, despite having given patient the treatment. Okay, or if the RPR fails to decrease fourfold by 1 year. Okay, but in pregnancy, we are only pregnant for 9 months. So let's say after treatment, the RPR fails to decrease fourfold. After you monitor the VDR, maybe after the 3rd or 4th month, then you will have to consider whether we should retreat the patient. Or if there is a sustained fourfold rise in RPR titer, meaning that the titer is even worse than pre-treatment titer. So that we have to retreat and also consider if there is any reinfection. Okay, we have to do a monthly ultrasound monitoring to look for IUGR or polyhydramnios, screen the partner and treat the partner if indicated, and also notify the disease. Okay, referral will also have to be made because patients with syphilis in pregnancy, they are tagged yellow and need to be seen by the FMS for assessment, counselling and also follow-up. Besides that, we also need to refer these patients to combined clinic and ONG for anomaly scan at 18 to 22 weeks. Okay, so for syphilis, it's not only enough to treat the patients, we must also screen the context of these patients. So examine and investigate the spouse and all sexual partners, trace partners for the past 3 months, as the incubation period for syphilis is rather long, can last until 90 days. Treat the partner if indicated. And we usually give an epidemiological treatment for asymptomatic context of early syphilis. When we say epidemiological treatment means we treat the partners of these patients with a stat dose of benzathine penicillin 2.4 mega units. Alternatively, if the partner is allergic to penicillin, then we can give doxycycline 100 milligrams BD for 14 days or azithromycin 1 gram single dose per oral. Okay, health education and advice. Okay, this is very important to ensure patients' compliance not only to treatment but also to follow up. Okay, so we need to explain on syphilis, the nature of disease, transmission, its complication in pregnancy, how to reduce risk, okay, compliance to treatment and antenatal follow-up. Okay, patients should avoid unprotected sexual intercourse until they and their partners have completed treatment, and to abstain from sex until 1 week after they and their partners have completed treatment. We should also stress on the importance of hospital delivery and follow-up and care of the baby post-delivery. So postpartum, we need to advise the patients on contraception. Okay, what sort of contraception will depend on the medical eligibility criteria. Okay, and the patients can breastfeed their babies provided that there are no lesions or ulcer on the breasts. Okay, advise patient on importance of early booking for the next pregnancy and refer to pre-pregnancy clinic for next planned pregnancy. Not forgetting, if the mother and the spouse has completed treatment or is still on treatment, we will still need to follow up their titres until at least 2 years. So transfer the mother and the spouse to continue follow up in OPD or STI clinic in the KK. Okay, so what about the exposed baby or infant? Okay, we also need to monitor the baby or the infant of these mothers. Okay, monitor the growth, developmental milestones and immunization of exposed baby or infant. Ensure that the baby or infant has proper follow-up under pediatrician. Make sure they are not lost to follow-up. And at the same time, we must always liaise with our colleagues from the hospital to know the progress and status of the exposed baby of an infant. Okay, because in the health, we will need to complete the documentation in the daftar case VDRL and TPHA form and also the buku daftar VDRL. So we will need to know what the baby's titer is when the hospital monitors them. Okay, so this is the example of the KKM-NT form that needs to be filled up for mothers with syphilis in pregnancy, and also the buku daftar, which we fill up for all mothers with syphilis in pregnancy. Okay, so in summary, this is the flow on how we manage pregnant mothers with syphilis. Okay, so once the pregnant mother is diagnosed to have syphilis, the mothers will be referred to the family medicine specialist in the primary care level. Okay, they will be given adequate treatment depending on regime suitable to them. Okay, they will also be referred to the ONG and combined clinic in the hospital with specialist care. patients need to deliver in the hospital setting, and the baby will be followed up under a pediatrician for at least 2 years. Okay, so these are some of the references that I have used for this presentation. Thank you.
Okay, thank you, Dr. Nick, for your presentation. We will go ahead and take some time for questions now. Just a gentle reminder, please be sure to submit your questions at the link provided at the YouTube description or at the WebEx chat box. You just click on the link so that we can capture the questions and answer them if we don't have enough time to answer it now. So Dr. Nick, kindly look at your chat box for the questions that we are going to answer today. Okay, so for question 1 from Amira Liana. Hi Dr. Mazlina, Dr. Nick Mazlina. I would like to ask if non-treponemal is negative but treponemal test is positive, is there a possibility that the test is false positive? Is there any role to repeat another treponemal test? For example, if first test is using the TPHA, then second test TPPA?
Yes, hello. Thank you very much for the question, Dr. Amira. Okay, so if the non-treponemal test is negative, meaning that the VDRL or RPR is negative, but the treponemal test is positive, meaning that the TPHA or DPPA is positive, then this patient most likely has actually latent TB or has had TB in the past and has been treated. Okay, so this is not actually a false positive test. A false positive test is when the non-treponemal test is positive and the treponemal test is negative. For example, our VDRL or RPR test is positive, but when we do a confirmatory test using the TPPA or the TPHA, that one is negative. Okay.
Okay, thank you, Dr. Nick Mazlina. So for question 2 from Intan Atirah binti Shahrin, the question is, at which titer do we usually start treating the patient?
Okay, so as in my presentation, if the titer is a high titer, meaning if it's more than 1 in 8, then usually we will treat the patient. Okay, but some patients come in with not so high titer, maybe 1 in 2, 1 in 4. So should we treat these patients? Okay, so whether or not we treat this patient will depend if the patient is able to give us a good history, or we have some medical documentation on the patient's past history. Okay, what I mean is, let's say the titer is 1 in 4, and we know from the notes or the patient's precise history that she has had syphilis in the past, completed treatment adequately, and the titer has been serofast, means it has been persistently 1 in 4 until this current pregnancy. Then you may not need to treat this patient. Okay, but if the patient is unable to give any clear history, whether they have been adequately treated in the past, what was their titer after treatment, then even if it's in 1 in 2 or 1 in 4, we will still treat the patient. Okay, and treat it for latent TB.
Okay, Alhamdulillah. Thank you, Dr. Nick, for your presentation and also the Q&A. Unfortunately, we don't have enough time for Dr. Nick to answer the other questions. However, we will answer them through email, where we will give the questions to Dr. Nick Mazlina and she will answer the questions. Okay. As for now, thank you, Dr. Nick. We now have a break until 11:15. So for you guys to have your own refreshments or maybe stretching a little bit. So see you guys back at 11:15. For the next topic, next two topic will be given by Dr. Karil Erwan, but the topics are very interesting for you to listen. Thank you. Okay, Assalamualaikum and welcome back everyone to our webinar today. So I hope you had enough rest just now. So we move on to our last presenter for today. For the last presenter, a thorn amongst the flowers, I present you Dr. Karil Irwan bin Khalid. Dr. Karil is an infectious disease physician at the Infectious Disease Unit, Department of Medicine, Hospital Kuala Lumpur. With vast experience in the local and international scene, Dr. Karil also has many publications on infectious disease, particularly regarding HIV and STI. Therefore, he would be the most suitable person to present the next two topics of the first one, updates on treatment of HIV infection during pregnancy, and the second topic, updates on treatment of syphilis infection during pregnancy, how to deal with penicillin allergy. These two topics will be beneficial, especially for KKs and GP to decide whether when to refer a case to an ID specialist or not. So I give the floor to Dr. Karil Irwan. So Dr. Karil, the floor is yours. Thank you.
Okay, thank you, Dr. Iza, for the kind introduction. Right. So, Assalamualaikum and a very good morning. First of all, I would like to thank the organizer for inviting me to speak today. My first topic would be treatment of HIV infection during pregnancy. It will basically be a follow-up presentation based from Dr. Nurul's previous slide. Yeah, so, okay, right. So, okay, let's start off with the first case. We have a 35-year-old lady, yeah, who was diagnosed of HIV via premarital screening. This is a second marriage. She was divorced 2 years ago. Her ex-husband's HIV status was unknown, and her current husband was also screened during the premarital screening and turns out to be negative. She's asymptomatic, and her Nadir CD4 was 450, about 19%. So the first concern that she has is that, will my husband get HIV too, now that she's HIV positive? So to answer that question, I'm just going to share with you some landmark studies on looking at HIV serodiscordant couples, yeah? Whether if somebody is HIV positive and the partner is HIV negative, whether the HIV transmission would be there or not. So the first paper, which is the HPTN 052 paper, looking at the about 1,700 sexually active HIV serodiscordant couples in stable relationship over the past 3 months. These couples were randomized into two arms. The first arm where they initiate ART treatment in early phase where the CD4 was still high, ranging from 350 to 550, and the second arm, they wait until the CD4 drops to less than 250, then they initiate ART. So it was actually published in the New England Journal of Medicine. Looking at this result, there were about 39 HIV transmission documented, and about 28 which was virologically linked transmission, and only one transmission happened when you start the HIV treatment earlier, and the other 27 transmission happened when you delay it until the CD4 drops to less than 250. But overall, there was 96% reduction in transmission to prevent HIV transmission from somebody's positive to the negative partner. Hence, it is recommended. So I think that would be the start off point where we actually introduce this HIV treatment as prevention to prevent HIV transmission from a positive partner to the negative partner. And then moving on to a partner study. Again, this is a large multi-center observational prospective study of HIV serodiscordant couples. It was done in 2 phases. The partner one, which was mainly a group of MSM couples and heterosexual couples, and partner 2 is exclusively for MSM couples. Basically, the aim is to look if we manage to start effective antiretroviral therapy for the positive partner, and we can bring down their viral load to a suppressed level of less than 200 copies. There should not be any transmission from HIV positive partner to the HIV negative partner. And there was no PEP or PrEP use reported in the HIV negative partner. So, so it is proven that there were no link transmissions documented in about 77,000 condom-less sex acts when a HIV positive partner with effective antiretroviral and has got the viral load suppressed. So if you look here, there's various sexual behavior reported by HIV negative partner. There were no linked transmissions documented. So with that landmark studies, back in 2017, CDC has sort of came up with this position statement or campaign that they agree that person with undetectable HIV cannot transmit the virus. Hence, the term U equals U means undetectable equals untransmittable. I'm sure you've heard of this term, that we want to initiate antiretroviral therapy early, and then so that they come to a suppressed viral load. So if they have been taking their antiretroviral every day, they have a undetectable viral load, they should not be able to transmit the virus sexually. Right, as I mentioned earlier as well, HIV treatment as prevention. We know that people living with HIV who take the medication prescribed as daily, they achieve undetectable viral load, and they do not have the risk of transmitting HIV to their negative partner. So moving on to the second question, can I still have a baby? All right, so when we talk about HIV positive women that plans to have a baby, we need to sort of engage them talking in about safe conception, and also and we plan. So there are guidelines out there that we can actually use to plan so that they have a safe pregnancy. So as now with all the new advances and treatment, people with HIV live longer and they have healthier lives. So safe conception counseling for HIV serodiscordant couples especially is actually a reproductive right. About 50% of HIV infected men and women desire to have children, and conception counseling should be included as a public health strategy to reduce HIV incidence. We need to integrate the effective HIV prevention strategies into comprehensive reproductive counseling, which is a rational step to protect the uninfected partner. So how do we go about to talk about this safe conception? How do we counsel and advise our couples whether they want to have baby or not? So basically, for couples with differing HIV statuses or serodiscordant couples, when the partner living with HIV is already on effective antiretroviral and has achieved sustained viral suppression, you may allow them to have sexual intercourse without condom, but limited to the 2 to 3 days before and the day of ovulation, which is the peak fertility period. That means the chances of them conceiving is much higher, which is an approach to conception with effectively no risk of sexual HIV transmission to the partner without HIV. Okay, so this is something that we are sort of advocating, practicing. So if you have a HIV positive wife with a HIV negative husband, so unprotected sex is considered safe when the woman is on HAART with good adherence and you have a documented undetectable viral load for more than 6 months, and you have STI. If you have STI, it has been treated. So you can allow to have time intercourse during the fertile period. Those days where I think there are some techniques which have been described, in terms of simple self-insemination and so on, is usually we don't encourage anymore. And of course, the use of PrEP, a short course of antiretroviral to protect the HIV negative partner. It's probably not indicated if the HIV positive partner is already on effective treatment with viral load suppressed. What about HIV positive husband with a HIV negative wife? So unprotected sex is considered safe, again, if the man is on HAART with good adherence, undetectable viral load for more than 6 months, and if they have STIs, it has been treated, because as you know, the concept of U equals U, which I've explained earlier, the HIV transmission from the HIV positive husband to the HIV negative wife would be 0. And then again, we allow time intercourse during fertile period. So this is something that we can actually help the couples as healthcare providers to sort of, teach them how to sort of calculate the ovulation cycle. And I'm sure there are a lot of devices, techniques and gadgets out there on methods of tracking ovulation. So we actually guide them on and tell them which would be the best so-called fertile window or period for them to have timed intercourse. All right. There are some people out there also asking, would there be any role of PrEP in seronegative partner in situation where the HIV positive partner is on HAART and the viral load is suppressed? So in these serodiscordant couples who attempt to have conception, when the partner is living with HIV has achieved viral load suppression, it is unclear whether by giving PrEP to the negative partner will actually further reduce the risk of sexual transmission. But there was a study which was done by Hoffman et al. Showed that actually if you add on PrEP, it does not, it adds little benefit when somebody who is already, the partner who is HIV positive already on active antiretroviral and viral load suppressed. So usually if we do not sort of recommend to add on PrEP on top of if the HIV positive partner is already on effective HAART and viral load suppressed. But saying that, there is a role of PrEP in serodiscordant couples. It is actually recommended in these situations where it is what we call as a breach, when the HIV infected partner has just recently started on HAART for less than 6 months, because we know that antiretroviral will probably take about 3 to 6 months for the viral load to suppress. So during that interim period, we may offer PrEP in the HIV negative partner until the HIV positive partner's viral load comes down, or the uninfected partner is unsure about the HIV status of their partner or whether their viral load is suppressed. But again, this is a case-to-case basis. Right. So I think from the previous presentations, I'm sure you've seen this cascade of service delivery for PMTCT as early as the first antenatal visit during booking, progresses towards the gestational age of 32 or 34 to 36 weeks until delivery. And then we talk about neonatal prophylaxis. So we have the HIV testing, and if it's positive, we offer antiretroviral, and then we do viral load between 32 to 36 weeks to decide on the mode of delivery, and then whether the infant born to the HIV positive mother, they need prophylaxis, whether 4 weeks or a combination regimen for 6 weeks, which I think our presenter will talk about it tomorrow. So it is sort of, it's already set out there. So I think that it's good that we just need to get ourselves tested during booking and also follow this cascade. Yeah. Now let's move on to case number 2. We have a 25-year-old single lady, primigravida, who was diagnosed HIV 2 years ago. She's HAART naive and not on follow-up. So she actually presented to Clinic Kesihatan at 8 weeks of POA. and then CD4 was 150 during the visit, and VDR was negative, and there were no signs of opportunistic infections, and she admitted to have multiple sexual partners before. So the question is, can she continue with her pregnancy without infecting the baby? So I'm sure all of you know the answer would be yes. So what we have in Malaysia at the moment, we have our Malaysian Consensus Guidelines on ART 2017. We are still in the midst of revising the new guidelines, I think because of the COVID pandemic, and also it was sort of postponed for a while, but it should be out soon. So what says in our local guidelines here is that when actually that we consider to start hard. In this guideline says that if the CD4 is less than 350, you should start antiretroviral in this group of women as soon as possible, right? And it should be so to start them earlier in the first trimester who presents with opportunistic infections or WHO clinical stages 3 and 4. But for those who still have high CD4, more than 350, sometimes we do commence antiretroviral until they reach week 14 of pregnancy. But I must say generally, when they present to us with newly diagnosed of HIV, generally we would start them on antiretroviral regardless of the CD4. And what antiretroviral to start, I think Dr. Nurul has actually shared with you in her presentation. As of now, we still consider or use 2 NRTIs, mainly our tenofovir and emtricitabine, plus an RTI, which is our efavirenz as a preferred antiretroviral or our first-line antiretroviral regimen for these pregnant mothers. And of course, there are alternative regime. As you can see here, you can actually consider using Combivir plus efavirenz, Combivir nevirapine, even combination with boosted PIs like our Calitra, and also integrase inhibitors if you have it, mainly raltegravir, but I will talk about it more about this integrase inhibitor. Okay, so if you see at the bottom of the page, and I'm sure from our previous presentation, you've heard that we have to consider using an integrase inhibitor, particularly our raltegravir-based antiretroviral in late presenting women. So who actually comes to you at more than 28 weeks of gestation, or unknown or high viral load, more than 100,000 copies per mil, because raltegravir would actually bring down the viral load much faster compared to the conventional NNRTI. All right, so I'm just sharing with you the draft copy of the revised guidelines, which is not out yet. There's not much difference compared to the 2017 guidelines. We still use preferred antiretroviral here, our good old tenofovir-M and efavirenz, but we do recommend to use an integrase inhibitor. We actually have included dolutegravir on top with raltegravir here as our preferred antiretroviral for those who present late at more than 28 weeks of gestation. Just have to be alert about dolutegravir because I'm sure you all know that from the SEPAMO study, the observational cohort of pregnant women in Botswana, they actually see that those women who are on dolutegravir is associated with higher risk of neural tube defects if they start taking dolutegravir at conception and up to first trimester. So you can still consider using dolutegravir, but it is recommended here if it's to be used after the first trimester of pregnancy, and only if they have been fully informed of the potential increase in the risk of neural tube defects. So you need to sort of counsel them, and if they agree with that risk, then you can consider, but provided it has to be beyond first trimester if you want to use dolutegravir, or else generally we use raltegravir for late gestation. And then the alternatives are the same with the 2017 guidelines. How to deliver, the mode of delivery according to the viral load. So generally, we will repeat the viral load at 32 to 36 weeks of gestation. Based on the viral load, then we sort of consider or decide on the mode of delivery. Generally, if it's less than 50 copies or suppressed, you can consider spontaneous vaginal delivery. If it's 50 and above, or those who are not suppressed, more than 400 copies or unknown viral load, generally pre-labor cesarean section would be recommended. Of course, this would be discussion with the obstetrician, because if there are other indications for the mode of delivery apart from the HIV indication, then again, we sort of have this discussion with obstetrician. Right. So how would you manage this lady? Based on the guidelines, we start 10 VM and efavirenz as soon as possible. Because the CD4 was 150, we add on Bactrim for PCP prophylaxis because the CD4 is less than 200. And then we counsel on compliance and adherence. We would assess the social support. We generally will follow up quite regularly, about 4 weekly. And then, as I've mentioned, we repeat viral load at 32 to 36 weeks. And then if it's suppressed, we may consider SVD, right? Moving on to the third case, we have a 34-year-old lady, Gravida tu Parawan in second marriage. She's a late booker at 31 weeks of gestation. Her HIV screening turns out to be positive. Her ex-husband is actually an active IVDU and currently in prison. And we performed the urgent viral load and turns out to be 520,000 copies per mil, which is really high. And the CD4 was about 360. Okay, so this is just to show you the summary of maternal to child transmission rates if there is no intervention. That means from a HIV positive mother, what are the chances or the risk of transmitting HIV virus to the newborn? Okay, generally in pregnancy, if it's no antiretroviral given to the mother, there's no intervention, generally the transmission may go up to about 20%. But it is important to appreciate that the risk increases sharply towards the end of the pregnancy, and during labor, it may go up to 50% if there's no intervention done. And of course, in breastfeeding, it goes up to about 30% of risk transmission as well. What is important is actually to know the HIV viral load near delivery, because this is one of the predictive factors of risk of HIV transmission from the positive mother to the baby. Logically, as we know, if the viral load is more, I mean, it's higher, like more than 10,000 and all, you see that the transmission rate is actually as high as 10% if the viral load is not suppressed near delivery, okay? So that's why we actually recommend usage of integrase inhibitor in those who actually come late during pregnancy. Generally, after 28 weeks of gestation, we need to start an effective antiretroviral to have a rapid decrease of maternal viral load so that the transmission from the positive mother to the baby is 0. So advantages of starting raltegravir during third trimester is because they have a higher first and second phase viral decay rate, means that they have a more rapid to bring down the viral load much faster. They have a high placental transfer. They would actually have potential preloading effect for the neonate, and they have effective accumulation drug level in the cervicovaginal secretions, all right? This is to show you that usage of integrase inhibitors in pregnancy, mainly raltegravir, dolutegravir, and alveltegravir, it actually has more rapid HIV viral load decline compared to efavirenz or boosted PI. So by week 4, you see almost 50% of the viral load would be suppressed, and up to week 12, almost 80% of those patients would have a viral load suppression if you were to use integrase inhibitors as compared to efavirenz. Okay, So again, I've reiterated this. Consider using raltegravir for women coming in late gestation, more than 28 weeks. And if you see them in clinic kesehatans or GPs and also, please refer them to the nearest ID physician so that we can do the needful, right? Now let's talk about intrapartum IV zidovudine infusion. So the dose that we give usually is 2 milligrams per kilogram in the first hour, and then followed by 1 milligram per kilogram per hour subsequently. So it is actually recommended to use if the mother's viral load is more than 1,000 copies per mil. So those women who present in labor, who has got ruptured membranes or admitted for planned pre-labor cesarean section. So we actually institute this IV zidovudine infusion, but it has no additional benefit in PMTCT if the woman or the mother is already on active antiretroviral and the viral load is less than 1,000 copies during late pregnancy and near delivery. Okay. So in this third case, when would you start HUD for this patient? Well, as soon as possible. What HUD regime would you start? As I mentioned, I would start tenvir-M and raltegravir 400 milligrams BD. Repeat viral load between 32 to 36, so at about 36 weeks, which would be unlikely suppressed in this situation because remember her viral load was almost 500,000 copies per mil. And most likely she would need an LSCS and intrapartum IV zidovudine. So you need to engage your colleague, your obstetrician, and also our pediatrician that, you know, this potentially that the mother's viral load will not be suppressed at labor. And what else would you like to do? As I mentioned, refer the baby to the peds for HUD post-delivery and also screen the current husband, all right? So women presenting in labor with no prior HUD exposure, as I mentioned, we should start IV zidovudine infusion immediately because I'm sure the viral load would not be suppressed. We should immediately give them a fixed dose combination of zidovudine and lamivudine or Combivé with raltegravir as a preferred third agent because it rapidly crosses the placenta. Zidovudine has, from evidence and data, shows that zidovudine has the property to reduce HIV transmission faster. And then if you don't have raltegravir, then we have to use nevirapine or efavirenz should be used in order of preference. So we usually give nevirapine. And after delivery, usually we will switch the antiretroviral back to the recommended first-line regime, which is your tenvir-M and efavirenz. Yeah. What about women presenting with spontaneous rupture of membrane? So the decision for the mode of delivery has to take into account what is the maternal viral load, the duration of the rupture of membrane, and the expected time of delivery. We need to know that there would be increased risk of perinatal HIV transmission of 2% per hour after rupture of membrane. And one of the complications of prolonged rupture of membrane is chorioamnionitis. And there is data showing that it is associated with perinatal HIV transmission if you have chorioamnionitis together. So delivery should be expedited for women with pre-labor rupture of membrane at term, either with induction of labor or C-section, but generally, usually we would proceed with C-section. And then there should be a low threshold to start antibiotics if signs suggestive of chorioamnionitis. I think from the previous presentation, we've seen this, our own local guidelines, the Garis Panduan, which I think probably Dr. Nurul has shared with you. Just to sort of summarize the Carta Aliran Pengurusan. So we need to sort of know when to refer to hospital, either with physician or ID physician, especially those who come in late, more than gestation of 28 weeks, because you may want to consider integrase inhibitors in this patient. And I know we don't have integrase inhibitors in clinic kesehatans, and also those who are viral load not suppressed. So please refer them early to us so that we can do the necessary. All right, so in a nutshell, U equals U. Okay, so I'm sure all of you know the concept of U equals U. Early HIV screening and diagnosis is important because if we detect them early, we can institute antiretroviral treatment early. It's also good for the patient, and also it prevents transmission to their negative partners. And then early initiation of antiretroviral and viral suppression is key. Again, in these days, safe conception and pregnancy is something that we need to talk about to our patients, especially the serodiscordant couples. And again, this has to be a multidisciplinary management. So usually the FMS will see them in the clinic kesihatan, and they will refer to our obstetrician or to our ID physician sometimes, and also getting the pediatrician involved as well for postnatal care for the babies. All right, so just to quote the UN Secretary General back in September 2009, he said that no child should be born with HIV, and no child should be an orphan because of HIV, and no child should die due to lack of access to treatment. Right, with that, I thank you.
Okay, thank you, Dr. Khairil, for your first presentation of updates on treatment of HIV infection during pregnancy. The case scenarios you included together with your presentation would certainly be useful or beneficial for our colleagues. Okay, now we would like to go ahead and take some time for questions now. Dr. Khairil, could you please have a look at the chat box in WebEx? And again, for all, just a reminder, please be sure to submit your questions at the link, at the question link at the YouTube description, or in the chat WebEx chat box, because the link will bring you to Google Form where you can ask your questions there. Okay, so for the first question for Dr. Khairil is from Dr. Norma. Is from Norma Yaakob. How about vaccine BCG? I'm not sure. The child with transmission, HIV and syphilis mother.
Okay, sorry, the question is how about BCG in the child?
In the child with transmissions.
Meaning the BCG vaccination to be given to the child. I think probably this would be best to be answered by Dr. Chu tomorrow, because I'm not a pediatrician, so I probably would answer other questions. Is that okay? Yeah.
Okay, sure, doctor. So we'll move on to question 2 from Nor Zarina. What is your suggestion for seroconcordant couple who wish to have children? How should it be managed?
Okay, so seroconcordant means both, yeah, HIV positive husband and wife both are HIV positive. Actually, there's not much difference compared to serodiscordant. It's just that when we have serodiscordant couples, the aim is to treat the HIV positive partner and also to prevent the transmission from somebody positive to negative. But if both are already positive, again, the treatment principles are the same. We need to get both of them on effective antiretroviral and their viral load suppressed as well. Some people would argue both already HIV positive. Why do you take the effort to, make them suppress or just allow them to have, sexual intercourse, that sort of thing? But again, it's not something that we recommend because of sometimes we do have the risk, what we call mutated HIV strains, that sort of thing. So we don't want that to happen. So again, the principles are the same. We would generally get both of them on effective antiviral, get their viral load suppressed, and then have the same sort of counseling on safe conception and pregnancy. Moving on.
Okay, Dr. Khairil, thank you. And the last question is from Peter. The question is, if HIV negative pregnant ladies with partner active IVDU and refuse to get his HIV status tested, can we start PrEP for this pregnant lady, and at which gestation?
So the pregnant lady is HIV negative, the partner is an IVDU, refused to get HIV status. So okay, of course, in this situation, the HIV negative pregnant lady has risk, yeah, because the partner is an active IVDU, even though the partner does not want to get tested. So of course, she's already in the high risk category, where Yes, I agree. PrEP would be beneficial in this situation. Again, starting PrEP in pregnant lady, as I mentioned earlier in my slide tadi, is basically just an interim stage where the partner, we still don't know the partner's HIV status here. So we need to know if the partner's HIV is positive, the viral load we still don't know, then we would start the PrEP and continue until, as long as there's always a risk of the partner to transmit the HIV to this pregnant lady, we will carry on the PrEP. Again, PrEP is a whole different thing. I mean, we need counsel and talk, because in order for PrEP to work, the mother has to take the medication on a daily basis. So generally PrEP, we offer Tenvir-M, yeah. So it's something that we also use for our HIV treatment for pregnant ladies. So generally, in terms of safety and efficacy, the data is out there. So it's generally safe to start PrEP with pregnant lady. And the gestation, generally, if as long as there is always a risk of getting HIV from the possible positive partner, you can actually start, but of course you need to exclude window period first lah. So you need to test the HIV out from the window period, and then you can offer PrEP. But again, you have to sit down and counsel, and we have to get the partner yang active IVDU to get tested. Because no point if the partner is HIV negative, then why would you want to offer PrEP for the lady unnecessarily, kan, to give extra medication while she's on pregnant? Yeah.
Okay, I think, thank you, Dr. Karil. I think that's all for the question for the first topic by Dr. Karil. The questions will be answered via email. So let's move on to the second topic by Dr. Karil, which is updates on treatment of syphilis infection during pregnancy. How to deal with penicillin allergy. Dr. Karil, are you good to go? Okay. All right. Please, Dr. Karil, the floor is yours.
Thank you. Let me try to share my slides. Okay, right. So moving on to my second presentation, treatment of syphilis infection during pregnancy. So I've been given the task to speak on specifically how to deal with penicillin allergy. So my slides would just be talking about this. I think previously Dr. Nick has covered the treatment and management of syphilis in pregnancy. So I move on to this. Right. The slide is not moving. Oh, okay, right, okay. So as an introduction, penicillin is recommended for all clinical stages of syphilis, yeah, and no proven alternatives exist for basically treating neurosyphilis, congenital syphilis, or syphilis during pregnancy. So penicillin is still the mainstay of treatment. In one large study in an STI clinic in the US, actually revealed it's only about 8% of patients actually reported penicillin or another beta-lactam antibiotic allergy. So the prevalence is actually quite low, and only about 7% had an objective positive test for penicillin allergy. So I would say penicillin allergy is usually often over-reported. And then with the majority of patients who report penicillin allergy able to tolerate the medication with subsequent measures to make sure that they are actually okay to carry on with penicillin. So this is, I pick up from our National Antimicrobial Guideline, looking at how do we approach or manage antibiotic allergies. Yeah. So adverse drug reactions, or in short we call ADR, is mainly categorized into two reactions. You have the type A reactions and type B. So type A are basically predictable reactions because of the drug compound itself. Yeah. Some drugs like our Bactrim, allopurinol, and things like that. Whereas type B reactions are unpredictable reactions, which are not usually related to the pharmacological action of the drugs. So type B ADR can be further divided into either immune-mediated, which is true allergy, or non-immune mediated, which is non-allergic. All right. So as I mentioned from my first slide just now, the estimated true incidence of penicillin hypersensitivity worldwide is generally low. Yeah, it's quoted less than 10%. The thing is about penicillin allergy, we need to appreciate that there is this thing called cross-reactivity with other drugs because of beta-lactam. I mean, we know penicillin is a group of beta-lactam antibiotics. There are other beta-lactam antibiotics, which are cephalosporins, monobactam, carbapenems, and sort of. So there is always this risk of somebody who's penicillin allergic would have cross-reactivity if we were to give other alternative antibiotics from the cephalosporin group. I will explain to that later. And then careful evaluation of antibiotic allergy and prior tolerance history is essential. Okay, you need to really evaluate is it really true allergy or not. And then alterations in antibiotic prescribing due to reported or so-called penicillin allergy has been shown to result in poorer clinical outcomes and also increased incidence of serious antibiotic-resistant infections because you use alternative antibiotics which probably be more broad spectrum rather than you use penicillin, so it causes more risk of MDR organisms and then prolonged hospitalizations and increased healthcare burden. So that's why we need to be very certain whether this is actually true penicillin allergy or not. So careful drug allergy evaluation with or without drug testing may lead to more judicious use of narrow-spectrum beta-lactam antibiotics when clinically indicated and will improve patient safety. All right. Okay, this is I just want to show you the beta-lactam antibiotics. So in the beta-lactam antibiotics, we have penicillin, cephalosporin, carbapenem, monobactam. So looking at penicillin and cephalosporin, they actually has almost similar structure. Yeah, they share the same R side chain, they share the same beta-lactam ring. So that's why somebody who has penicillin allergy, if you try a different type of antibiotic from the cephalosporin group, let's say your ceftriaxone, you may have this risk of cross-reactivity, but it's actually generally very low. Yeah, so this is a table from our NAG as well, looking here that if you have true penicillin allergy, the cross-reactivity is much higher if you were to use the first and the second generation cephalosporins. But as the generation goes higher from third generation and above, the cross-reactivity will become lower. So if you see from the next slide, when you have penicillin allergy for syphilis, they actually recommend you to use ceftriaxone. So in this situation, the cross-reactivity concern is much less. So generally, they can be given ceftriaxone if you're worried of cross-reactivity. Okay. So evaluation, again, patient history is very important. You have to assess detail on the allergic reaction. The source of the allergy history is important, whether it's from the patient or the family member or even from the healthcare professional. The specific antibiotic that was prescribed and the type of the infection treated, if that's possible to obtain, the antibiotic dose and the route of administration, what are the signs and symptoms experienced together with the time of onset. So usually it is good to make some sort like a chronology to see whether the symptoms and signs correspond with the time of initiation of the antibiotic. And then medical evaluation conducted if it was done whether any allergy cards, whatnot has been issued, what was the treatment given for that so-called allergy, and what was the response. And then the medication taken since the occurrence of the reaction, the recurrent signs and symptoms occurring after using the same antibiotic or subsequent antibiotic exposure. And also we need to document the concurrent medication at that time because patients might be on some other medication apart from the penicillin, so that could also cause allergy reaction. So it's not purely because of the penicillin. And then prior tolerance of other beta-lactam antibiotics and other antibiotic needs to be assessed as well. Okay, so this is a table to show you, are we really dealing with a true penicillin allergy or it's not? Okay, so for penicillin allergy, or what we call hypersensitivity reaction, we have type 1 and type 4. Okay, so type 1 is basically true allergy, or what we call IgE mediated allergic reaction. So the symptoms or the signs would actually happen very fast after you give penicillin to the patient. So generally less than an hour after the first dose of the penicillin. So the patient may experience cutaneous symptoms, particularly urticaria, pruritus, and flushing. The severe ones may get angioedema, they get rhinitis, conjunctivitis, bronchospasm, and hemodynamic instability. So this is likely type 1 hypersensitivity reaction, which is a IgE-mediated true allergy to penicillin. But some patients may develop type 4 or delayed hypersensitivity reaction to penicillin. So the symptoms and signs occur more than an hour after the exposure of the penicillin. So these are the non-IgE mediated, but they are also categorized as hypersensitivity or allergy. So they get delayed onset of cutaneous manifestations such as all these varying rashes, pruritus, and whatnot. They might get systemic responses, which are the more severe ones like DRESS, Steven-Johnson's, TEN and whatnot. And they can also get this rare, because it's more of a systemic manifestation, they get other rare systemic reactions such as hemolytic anemia, and even they get interstitial nephritis and vasculitis. So these are true allergies to penicillin as well. So what constitutes unlikely hypersensitivity reaction to penicillin is basically when there's no temporal association between the symptoms and the exposure. So sometimes in real life it's quite difficult to tell, but some situations it is quite straightforward that the symptoms happen which does not correspond to the exposure of the penicillin. And when you are able to elicit that subsequent exposure with the same drug, they do not develop the same reaction. Okay, so you know that it's most likely it's not related to penicillin. Okay, and the symptoms that present are not suggestive of immune mediated. So some patients may complain of headache, blurring of vision, GI symptoms. So it's not immune mediated reaction. So it is something less likely to be hypersensitivity reaction. But of course, generally we are usually faced with this indeterminate. We cannot be able to tell for sure that it is really hypersensitivity or not. So again, the temporal association between drug administration and onset of symptoms is unknown. Vague history with no details. Sometimes they've been told that when they were in their childhood they have been labeled a penicillin allergy, whether they are uncertain the onset of symptoms and all. So in this kind of situation, sometimes you have to further investigate, and you may want to consider referring them to an allergist or a dermatologist to do further testing. Okay, right. So we have this thing called skin testing. So when do we need to consider referring a patient for a skin testing? So in the National Antibiotic Guidelines, it says that if the patient requires frequent antibiotic use, if they are immunosuppressed, they may require narrow spectrum antibiotics such as penicillin. Patient is planned for elective surgery, or they have reported documented multiple non-chemically related antibiotic allergies, or they have suffered anaphylaxis when a beta-lactam antibiotic has been administered concurrently with other agents. So you have to consider referring them to the allergist or a dermatologist for skin testing. Okay, but skin testing is not for screening. Okay, it is used to sort of determine whether it is really true penicillin allergy or not. So in our context of syphilis in pregnancy, whereby I've mentioned that penicillin is the only drug treatment of choice. So referring them to allergists or dermatologists would be important to actually really determine whether there is true penicillin allergy or not, because we try not to use other than penicillin in syphilis in pregnancy. All right. So basically, to recap, as I mentioned, we need to obtain a thorough medical history, including previous exposures to penicillin or other beta-lactam antibiotics. And then if you decide to refer them for a skin test, it has to be evaluated by using the penicillin major and minor determinants. These major and minor determinants are quite technical. Basically, it's just a compound of what they actually use for the skin testing. And then those who actually have a negative penicillin skin test, that means negative penicillin skin test, you should actually perform an observed oral challenge with 250 milligrams of amoxicillin before proceeding directly to the treatment that is indicated. Okay, but for somebody who has a positive skin test reactive to penicillin, generally we would avoid using beta-lactam antibiotic or penicillin in this matter. Usually it's not advised. But in syphilis in pregnancy, as I mentioned to you just now, that the only therapy option is actually penicillin. So even though their skin test is positive, you may want to consider this thing called induction of penicillin tolerance, or in short, we call it as penicillin desensitization. So usually it will be done in a hospital setting with usually it'll be done in dermatology clinic. So it's something that we need to attempt to desensitize before we decide whether, look, this patient cannot receive penicillin, then we have to think of other alternatives. Okay. So what do the various guidelines out there say when we deal with syphilis in pregnancy who has got penicillin allergy? So in 2017, the WHO guideline, it says here that in someone who is, pregnant with early syphilis, it is stated here that if the benzathine or the procaine penicillin cannot be used due to either allergy and it's not possible to do desensitization, or there's no stock of the penicillin, especially in developing countries, WHO SDI guideline actually suggests use with caution erythromycin 500 milligrams QID for 2 weeks, or ceftriaxone 1 gram intramuscularly daily for 10 to 14 days, or azithromycin 2 gram once a day. For those who actually present in late syphilis, that means either more than 2 years duration or unknown stage of syphilis, if you cannot give benzathine or procaine penicillin because of allergy and you cannot desensitize, or there's no stock of the penicillin, WHO SDI guidelines suggests using with caution again. So the keyword is caution, because we know that other than penicillin, the treatment, there's not much data out there. So erythromycin 500 QID for 1 month. Okay. What about CDC guidelines? So this has actually been published quite recently in July this year. So in CDC guidelines says, again, for pregnant women, there's no proven alternatives to penicillin for syphilis in pregnancy. So again, here it is stated that pregnant women with history of penicillin allergy should be desensitized. Okay, so we need to consider desensitization and treat it with penicillin. So you may have to consider doing skin testing or oral graded penicillin dose challenge, which is the desensitization. So it might be helpful to identify women at risk. So tetracycline and doxycycline are to be avoided in the 2nd and 3rd trimester of pregnancy, right? And again, I think as Dr. Nick has mentioned earlier, erythromycin and azithromycin should not be used because even it treats the mother, but it does not reliably cure the maternal infection because it does not cross the placenta. So the fetus will still need to be treated as congenital syphilis, even the mother has received erythro and azithro. And there are data insufficient to recommend actually ceftriaxone and other cephalosporins for an alternative for penicillin allergy in pregnant women. What about the European guideline from the IUSTI guideline, the International Unions Against STI guideline in 2020? Again, I've already highlighted in that red box, for somebody who is pregnant, has got penicillin allergy, the way to go is to desensitize with penicillin. Okay, the UK guideline says the same thing. There's no penicillin alternative, including ceftriaxone, which are limited data. So again, we need to consider desensitize with penicillin. All right. This is our local guideline. Okay, I'm sure you've seen it. So it is also shared here that for somebody who has syphilis in pregnancy, the early syphilis, if you see in the alternative column, those who are allergic to penicillin, by right, you should get them desensitized. If they can't, then you have no other option. So you can actually consider using this alternative based on what WHO actually has recommended by using ceftriaxone, EES, or azithromycin, right? Again, here the comment has been highlighted. Penicillin regimen appropriate for women's stage of syphilis is the only known effective treatment recommended during pregnancy. And here again, it is also highlighted erythromycin should not be used because of the high risk of failure to cure the fetus. As I mentioned, the pediatrician should be alerted if the mother only received erythromycin because the baby needs to be monitored and treated prophylactically for congenital syphilis. Again, here for somebody who comes in with late syphilis, this would be the alternative option. You may have to give erythromycin up for a month. Yeah, and imagine taking erythromycin for a month with the GI intolerance and so on. So the risk of adherence would probably not be very, the risk of non-adherence would be high because, you know, taking erythromycin, it can cause nausea, vomiting, and all, and taking for a month. So of course, there is always a risk of failure of treatment if you were to give alternative macrolide treatment for syphilis in pregnancy. And then for neurosyphilis alternative, you can actually consider using ceftriaxone, 2 gram IM or IV for 10 to 14 days, provided there's no anaphylaxis to penicillin. As I mentioned just now, penicillin and cephalosporin, they have cross-reactivity, yeah? So just make sure that they have no anaphylaxis to penicillin. Okay. Moving on. Right. So this is something which has been shared by my dermatology colleague in HKL. Based on this paper, this is how they actually do the penicillin desensitization. So this was published in the Journal of Allergy Clinical Immunology in October 2020, whereby they use this oral penicillin desensitization protocol. So there are 14 steps altogether, which each step it has to be done in 15-minute intervals. Yeah. So cumulative dose is about 1.3 million units, given a total of 3 hours and 45 minutes, yeah, for the 14 steps. So our KKM syrup penicillin formulation, we have the syrup pen V 125 milligrams per 5 ml, which is equivalent to 40,000 units. So if you look here, steps 1 to step 7, we were supposed to desensitize them with only 1,000 units. So you need to dilute them with 1 ml of the syrup and then dilute into 40 ml to get 1,000 units. All right. And then moving on from step 8 to step 14, based on the recommended unit to desensitize. So you need to do what we call serial dilution. And then we need to desensitize them every 15 minutes until they successfully desensitize. Okay, right. So in summary, penicillin is the drug of choice for syphilis in pregnancy. the estimated true incidence of penicillin hypersensitivity worldwide is generally low. That's why we need to have a careful and a thorough evaluation of penicillin allergy with or without skin testing is crucial so that we can provide optimal treatment for the pregnant mother and the baby. And then penicillin desensitization should be attempted, if possible, before we resort to alternatives like macrolides and ceftriaxones. And then multidisciplinary management is important again. So please refer and discuss with dermatologists, and if you have an allergist in your hospital or with the ID physician, even with the obstetrician as well, and pediatrician, that we need to have a consensus on how we should manage this syphilis in pregnancy that has got allergy to penicillin, right? So with that, I thank you.
Thank you, Dr. Khairil, for your thorough and concise explanation on how to manage penicillin allergy in treatment of syphilis infection during pregnancy. I'm sure it's very beneficial for everyone. So we would like to go ahead and take some time for questions now. Dr. Khairil, please have a look at the chat box. Okay. For question 1 is from Mr. Peter. It's quite a long question. I'll just read it out loud. If a patient with initial titer of 1 in 16 and was asymptomatic, diagnosed at pregnancy, completed 3 doses of IM benzapenicillin, and repeat titer at 3, 6, and 12 months, remains at 1 in 16, and patient denies high-risk behaviors after diagnosis of syphilis, and partner is negative. Do we give repeat cycles of 3 doses of IM benza? And if so, the titer remain 1 in 16 after 1 year. Do we still repeat IM benza injection, or we can do LP, lumbar puncture, to look for asymptomatic neurosyphilis?
Okay, thank you, Peter, for the question. Okay, let me try and comprehend your question. So if somebody with a titer of 1 in 16 asymptomatic diagnosed at pregnancy, I'm not sure what gestation at that point of time. So presumably completed 3 doses of benzathine penicillin. So repeat. So generally, if you have syphilis, you have been treated in pregnancy, you should monitor their RPR monthly until they deliver, not 3, 6, 12 months. But generally, after, even if they have delivered, the titer remains at 1 in 16. Generally, kalau tak ada symptoms, we don't treat post-delivery lah. I assume this already been delivered. We will monitor because we would expect to see a 4-fold reduction of the titer up to a year. So if, let's say, after a year, the titer remains the same, but you have excluded reinfection, then it is wise to actually consider doing an LP to rule out neurosyphilis. But here you also mentioned that the partner is negative, but generally, even the partner is negative, we would actually institute epidemiological treatment for the partner. So we would actually give 1 dose of benzathine penicillin to the partner, even though the partner is negative. So if you need to treat, we usually just give 1 dose of benzathine penicillin because it's still within 2 years from the last syphilis. We don't need to repeat 3 cycles of benzathine penicillin. So I hope that answers your question, Peter.
Okay, thank you, Dr. Khairil. Okay, so for question number 2 from Surya Devi, the question is, if we need to start pre-exposure prophylaxis to negative partner, what regime and dose do we give?
Pre-exposure prophylaxis. I assume you're talking about the epidemiological treatment of syphilis, right? To the negative partner. So, right, pre-exposure prophylaxis. So I assume it's an epidemiological treatment of syphilis for the negative partner. I think tadi Dr. Nick has shared with you. So if there is no penicillin allergy for the partner, we give 1 stat dose of IM benzathine penicillin, 2.4 mega unit. But if the partner has allergy to penicillin, then we will offer them oral doxycycline just for 2 weeks, 100 milligrams BD for 14 days. Yeah. I think there's another question up there, kan? It's from Jazlan.
Yeah. Oh yeah, ada satu tu. You have time to answer? Okay.
Yeah, okay.
Okay, I can. The question is, why is the treatment regime differ from National Antibiotic Guidelines 2019? The NAG recommends treatment based on trimester, not based on history of infection. Which one should we follow?
Okay, I think I know what Jazlan mean here. If you look at the NEG 2019, it has been divided into syphilis treatment based on the trimester because it's only referring to the early phase of the syphilis. That means if you have primary, secondary, or early latent syphilis, actually that chapter I actually was the one of the author of the chapter. I know it creates a little bit of confusion because I actually divided the early syphilis based on the trimester, because if you look there, if it's first and second trimester up to 27 weeks of gestation, you just give 1 stat dose of benzathine penicillin. Okay, that one clear lah, the same. But at third trimester, that means if somebody comes to you with early syphilis but beyond 28 weeks of gestation or third trimester, it is recommended to give 2 doses. That means day 1 and day 8. That means weekly 2 doses. I know in WHO guidelines only says once, but there are some guidelines in the UK guidelines, the BASH guidelines, and I think it's also mentioned in CDC. You may consider giving 2 doses because of the physiological changes in pregnancy. So there are some concerns about the administration of the penicillin, whether the volume of distribution of the penicillin is adequate ke tak because of the physiological changes of pregnancy. So there are some experts recommending to actually use 2 doses. Tapi if you follow our current WHO guidelines, actually 1 dose is enough. So don't have to give 2 doses lah. Yeah. But if you follow British guideline, they actually ask to use both. So, you know, different guidelines are different lah. But I think just to make everything standard, we follow WHO guidelines, we just give 1 stat dose is enough.
Okay, thank you, Dr. Khairil, for the explanation. As everyone know, Dr. Khairil also is one of the author for the Antibiotic Guidelines 2019. That's why his explanation was very thorough, and I hope everyone can understand and can manage accordingly. Okay. So thank you, Dr. Khairil. I think that ends the session for today. Thank you very much. Okay, I will proceed. It seems that that's all for for today, as we are all already finished with our final speaker. So I will proceed with a recap of what happened today by sharing a slide. So what we had today in day 1 of our webinar for today, we had a keynote speech by Dr. Anita, followed by 1 topic, management of HIV in pregnancy at primary care level, given by Dr. Narul Aida binti Saleh, and followed by the topic by Dr. Nick Mazlina binti Muhammad, title of Management of Syphilis in Pregnancy at Primary Care Level and Importance of Early and Adequate Treatment. And the last topic, which has 2 topics, given by Dr. Khairil Erwan bin Khalid, title of Treatment of HIV and Treatment of Syphilis Infection during Pregnancy, and how to deal with penicillin allergy. Okay, that's for today. And I would like to tell you all about tomorrow's agenda in day 2. Tomorrow we will have 5 topics. The first topic will be given by Dr. Muniswaran, with the title of Management of Labour and Delivery of HIV-Infected Mothers, How to Deal with Unbooked Cases. Okay, topic 2 by Dr. Woon Hyun Yan, title of Management of Labour and Delivery of Syphilis-Infected Mothers. Is there any opportunities to prevent syphilitic stillbirth? Third topic by Dr. Chu Chong Ming, Management of Infant Born to HIV Syphilis Positive Mothers. The fourth topic, Screening and Diagnostic Testing of HIV, Ensuring Quality in HIV Diagnostic, given by Dr. Rozainani binti Muhammad Zain. And the last topic about Screening and Diagnostic Testing of Syphilis, Role of RDT in Antenatal Screening, given by Dr. Nur Aini binti Ismail. So tomorrow's topic is quite interesting and very informative for everyone. Hope everyone can join us tomorrow. And how to join? You can go on to this link. You can capture or screenshot now or look at the YouTube later. bit.ly PMTCT Day 2. Okay, gentle reminder for everyone. Please register your attendance at the attendance link at YouTube description below if you're using YouTube or at the WebEx chat box. Questions to speakers can be submitted using question link at the YouTube description or the WebEx chat box. You just click on the question link and you will be brought to a Google form. So you can ask your questions directly to specific speakers at using the Google form if you click on the link provided. We will try to answer questions during the Q&A session. If time doesn't permit, we will try to answer through your email. And make sure your internet connectivity is good. Okay? So see you all tomorrow. Thank you for listening, and we apologize for any shortcomings or mishaps that happened today. Assalamualaikum and thank you.